I think we should start because now abhi Seema Pandey is in OT and she will finish it by I think she will take 10 minutes more.
ठीक
So
है.
by the time we can start introduction and other things. If another car has been joined, I don't know if she is there or not. Or you can alone can start.
Okay.
I think so. You should start.
Ma'am,
Hello,
Sharda Jain,
hello
ma'am.
everyone. Hello.
Yes, ma'am.
Hello.
Hello.
Hi, Dr.
Hello,
Lumba, Jyoti, Aradhana.
Hello.
नहीं मैं
Hi.
तो मैं
Wish
आपकी
you
सुन रही
all
थी
the best.
बातें
Wish you people
कोविड की
all the best. All the best. We hope to listen a good news very soon. I have already voted. I don't know about others.
Hi
मैं तो
ma'am. Lily
मैं
ma'am.
कोविड
Hi.
की सुन हेलो मैं कोविड की सुन रही थी आपकी बातें तो इट वाज रियली हॉरिबल मैंने भी 3 साल काम बंद कर दिया था और
मैम
उसके बाद
हमारे यहाँ
काम
पे
पिकअप नहीं हो रहा ये प्रॉब्लम बहुत आ रही है मुझे तो
मैम you can मतलब we could see that black fungus, the whole of this half of the part of the mandible was gone. I mean this maxillary area was gone. We have seen
ओ माय
that thing
गॉड
and eyes are popping out. मतलब I have seen these things in my
ओ माय
hospital because
ओ माय
my husband is a nephrologist, so all the patients were sent to her. जब पेशेंट मरने वाला हो ना तो लाइक क्रिएटिनिन अगर 1.5 भी होगा ना और मरने वाला होगा तुम्हारी किडनी खराब है जाओ वहाँ पे. Otherwise, they keep on treating the patient who are having creatinine even more than 10. So it's like that. So it was a really horrible time because all those sickest patients were with us. And it was a very, I don't know, ma'am, something is, your own immunity or something like that. Even a 80-year person who was like a CRF, he came out of the COVID very safely. And young people, one of the MR from Senjaim, उसकी wife, she was pretty young, 1 साल का बच्चा. Like, totally, I don't know what was there. It's some, personal like susceptibility or something like that. Dr. Jyoti, Jyoti
Yeah.
Malik.
Yeah.
He's
Correct,
sending you
start,
the,
I think.
that, he is sending you all the welcome notes and everything. I think he's giving flow of the program.
Okay,
Check.
webinar
Because Ekita has not joined, so you better you start. I asked him that give it to Dr. Jyoti. She will start because the time is it's already 5:12.
Yeah. It's all 5:10 already.
Yeah. So if you have received that thing.
Hello.
Yeah.
Hello.
Hello.
Yeah, hi.
Good evening.
Hi, Dr. Aradhana.
Hi. Jyoti, have you received this flow of program? The full flow of this?
I don't know the flow, but I'll go with the flow, whatever is flowing on the screen.
Okay, so you start with the welcome note. It's
Yeah.
better you start with the welcome
Yeah,
note.
I'll start. And since Dr. Sharda Jain, ma'am, our chief guest is already here, so we will take her blessings. In the meantime, people would join. And I think first panel is you are moderating, Dr. Radhana. So if you have your panelists ready, then we can start. Your panelists are there?
I
Because
am not having the question right now.
see, the panelists in your panel are Dr. Jyoti Bali, Dr. Smita Arora, Rakhi Singh, Dr. Anshu Jindal, Dr. Poonam, Dr. Shivani, Ranjita, Dr. Divya, Dr. Anju, and Ekika. So actually,
Madam Abha Mazumdar has joined or not? Because she is
Dr. Abha has not joined.
expert.
Dr.
Yeah,
Abha, I cannot see Dr. Abha Mazumdar, ma'am. I can see Dr. Anu Pandey and Dr.
Shweta
Okay,
is there. Yeah.
but people who are in the panel are not there as yet.
Yeah,
So
even all the panelists are not here.
yeah, so because if we can take blessings from Dr. Sharda ma'am, but after that, then we have to continue. No?
Few words by ma'am.
We can take her blessings, but after that, are you ready to start the panel? Because ma'am can take 5 minutes with her talk or blessings.
By the
But
time you
after
introduce the panelists, the chairpersons,
Yeah.
and madam's message, I think
Okay,
by
so
that
I
time
should
others
start.
will.
Yeah,
Yes,
Should
yeah.
I
please,
start?
better.
I think
Yes,
so
please.
then because we have to read the CV of panelists also.
Okay, right. So, who's there from Corona Remedies? Who's
Anu,
taking care of the?
Yeah,
Mehul is here, I think.
yeah, ma'am. I am here.
Yeah.
Okay.
So,
So,
Anu, we have the CVs ready, no, of everybody,
yes, ma'am.
right?
Hmm.
So, you would start the recording now, so that and open it to the delegates. Have you opened it?
Yes, ma'am. And I have started this live stream also.
You have started the live
Yeah.
stream, right? Very wonderful.
Okay.
So, good evening, everybody. And today evening, we have the Azamgarh Obs and Gynae Society in association with Delhi ISAR and Haryana ISAR presenting us this evening with ISARians too. So, this webinar, we have the blessings of our President ISAR, Dr. Nandita Palshetkar ma'am. You can keep on changing the screen. If you have the CVs, you can please put on the CVs of Dr. Nandita ma'am and all. You can leave this, yeah. So we would be having the lamp lighting ceremony and Saraswati Vanna, followed by which then we would be proceeding with our chief guests' blessings. So yeah, you can please play the Saraswati Vanna and do the lamp lighting.
Okay.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्युर्मामृतं गमय ॐ शान्ति शान्ति शान्तिः या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा
मैडम शारदा का CV लगा दो.
So
मैडम
with the blessings of Ma Saraswati, we go ahead and we have our national ISAR team. We have our president, Dr. Nandita Palshetkar ma'am, president-elect Dr. Amit Patki sir, President-elect Foxy Dr. Sunita Tendulwadkar, Vice President ISAR Dr. Madhuri Patil, Honorary Secretary General Dr. Sujata Kar, and Treasurer ISAR Dr. Asha Bakshi ma'am, who have sent in their blessings and their good wishes. And hopefully in between, as soon as they join, we will take their forwards. Now, we have our chief guests for today's evening, Dr. Nandita ma'am, Dr. Amit Patki sir, who are yet to join. But we have a very, very, I would say, a person who does not, I mean, who cannot be explained in words, Dr. Sharda Jain ma'am, because she is
मैडम
such
इस CV की जरूरत नहीं है मैडम प्लीज मैडम
मैम
she
you are
is a
teacher of teachers.
multifaceted-
Ma'am is a
CV की
teacher
जरूरत
of
नहीं है
teachers.
प्लीज
So ma'am would not I would request Dr. Sharda Jain ma'am to please say a few words and give us your words of wisdom and bless us with your kind words.
I must say, Seema is not here for
She's
inviting
there,
me.
ma'am. She's
Huh?
joined. She has joined.
The
She's
Seema
come.
is there. Okay.
Yeah.
Ma'am,
Seema, how can I
ma'am,
miss you? Huh?
ma'am,
Oh,
pranam,
thank
ma'am,
God you
pranam,
are
ek
here.
topic.
No, at the outset, thank you very much, Seema, for involving me for this academic event. And I think, the two panels which you have, this thing, I think I will be able to learn quite a bit things with that. The medical science is evolving. Every 5 years, things change. And in ART, it is much faster. And for an ordinary gynecologist like me, it is very difficult to keep themselves updated. And thanks to these kind of webinars, that things are a bit possible. I was just talking to friends earlier that the COVID has taken away a lot of our friends and family members, but the blessings has come in the form of webinars that now you can outreach anybody in the country without taking any advantage from the drug houses. Here, I just wish to tell, it may sound very blunt, it's a truth reality, is that how many of us are able to attend international conferences that is also on their own, from their own pocket. There's all the drug houses are sponsored, and those lucky ones, when they come back, they do not update their colleagues across. I think we require 50 dedicated people who take onus on them that they will update, give the knowledge and give the skills to the people who are part of this organization called ISAR, that they will do it. And that's the reason I think, I joined IVF very late. In 2007, I joined. Being a teacher, I thought, probably I don't need to join IVF. But, once I joined it, I found there's so much of secrecy here. Nobody wants to share anything. And then I took an onus that as a teacher, I will see to it that one of the best courses in the country, I'm going to put it. And what is the secret of that particular success is I share what I do. We share the protocols, we share everything, share the lab. And I think in a very small way, we are successful. My request with the folded hand is that a few of you can definitely take onus on this, that whatever you learn new, please teach. Everybody has secrets. And those secrets need to be shared. And then only this particular country will be Viksit Bharat as far as IVF and infertility is concerned. And I think I'm looking forward to presentations and sharing of experiences. I again wish to tell you the second part of it. People make big lectures, but they never share their experience. वो इजराइल का एक्सपीरियंस बताएंगे, यूएस का एक्सपीरियंस बताएंगे, सबका एक्सपीरियंस बताएंगे, अपना एक्सपीरियंस नहीं बताएंगे. Time has come to open up. People like only those teachers who share their experiences. And I think, my request to everybody here, is quite a few of them I know here, that we become honest, become a good teacher. आप इतने बड़े-बड़े ऑफिस बेरर बनने जा रहे हो, कुछ तो करो हिंदुस्तान के लिए, हिंदुस्तान के लोगों के लिए. The celebrities are here only 1% of the country. 99% की कुछ तो सोचना ही पड़ेगा. So I think this particular remark may sound very blunt, but that's a reality and the need of the hour. That whatever you have your secrets, please share with people. Thank you very much. India is very different than US. India is very different than Israel. India is very different than UK. We are different. Our needs are different. Thank you. Thank you very much.
Thank you so much, ma'am. Thank you. I mean, that is why I said you are very different, because you speak from your heart and you speak very openly and very transparently. And you have spoken such a big, you opened such a Pandora box that people do not share their experiences, they do not teach. And that should be done for people who are still upcoming and learning. So a very important issue that you've brought. Thank you so much, ma'am, for your kind words. And we move on to our guest of honors now. We have for today evening, our guest of honor is Dr. Tarini Taneja, Dr. Renu Chugh, and Dr. Archana Verma. So can I have the CVs of Dr. Tarini Taneja has not joined as yet, I suppose. Dr. Renu Chugh is there. So can I have Dr. Renu Chugh's CVs, and I can invite Dr. Renu for her kind words. Dr. Renu is a consultant IVF specialist at Chugh Multispecialty Bhiwani, and she has been in practice for the last 35 years. She has received the President Foxy branch Bhiwani Award. She was president of Haryana ISA. She actually is still, we would be taking over from Dr. Renu Chugh now this January for Haryana. And wonderful work she has been doing for Haryana ISA in these last 2 years. She's also recipient of the Rashtriya Gaurav Award and awarded the professorship by Imam Scroll of Honor during MSCon 2016, and she has the honor of giving first test tube baby to Bhiwani. She has been an active participant in the seminars, both national and international, and her special interest is ART and endoscopy. And over to Dr. Renu for her comments and her wishes and her guidance.
Good evening, friends. Greetings to all and one from Bhiwani as well as Haryana chapter of ISAR. It's my immense pleasure today to be a part of this webinar. And special thanks to Dr. Aradhana and Dr. Seema for inviting me for this. I wish you all the best, Dr. Aradhana, for this webinar. And of course, it is an opportunity to meet so many dignitaries today at one platform. And the topics which you have chosen, they are really fantastic and very practical. PCOS is a complex thing. So more and more research is being done. It is getting day by day, new things are coming up, but still it is not clear. So many things still remain unclear. So I think today, from so many good panelists, speakers, moderators, everyone, all the delegates, as well as each one of us are going to enrich our knowledge, and we'll be able to treat our patients in a much better way, and we'll improve our results. And as Dr. Sharda has said, that we must share our experience. So these webinars, they are one thing. They are a part of sharing the experience. And Corona has taught us this. After the Corona has come up, so we are holding so many webinars, sitting at home, we can enrich ourselves and increase our knowledge. So Dr. Aradhana, wish you all the best for your this forthcoming elections, and all others, I wish them good luck from the core of my heart, and all the best again. Thank you very much.
Thank you. Thanks a lot.
Thank you, Dr. Renu. So moving on to our next guest of honor, we have another very, very clear, transparent, and very bold personality for the evening today. We have Dr. Archana Verma. Dr. Archana Verma has been the Vice President Foxy 2021, Founder President West UP ISOPAB Chapter, Advisor UPCOG, Organizing Chairperson UPCOG 2020, Past President Ghaziabad Obs and Gynae Society, organizers of so many conferences, Organizing Secretary of North Zone Foxy, of Midterm UPCOG, and so many others, as we can read in her CV. She is a Dhira Awardee 2022 for Women's Health, a DC Datta Award for Best Foxy Focus, India's Book of Award winner, President Foxy Best Committee Appreciation Award, and Abdul Kalam Excellence Awards, Women of Health Year Award, and so many others. And she has been a Wonder Foxian Award she has got for her reproductive health for women, work for in this particular area. And she is a champion of Foxy 2019, and a leader who has made an impact. Over to Dr. Archana Verma to with her words and for her blessings.
Thank you, Dr. Jyoti, for such a long introduction. And I think I will speak less because there are so much. It's a long program, and the time is something very precious. And really, thank you to my all-time, my favorite, my buddy Seema Pandey. And Dr. Jyoti Malik, of course, she is the one who makes that fire burning inside everybody. And really, Seema, you have done one very wonderful word, a thing that my mentor, Dr. Sharda Jain, is here, and Dr. Nandita Palshetkar and Amit Patki. I mean, I must say that I'm not new to ISAR, but somehow I was busy in other activities, as you see my CV also. But now I think I'm going to do some work, and this thing, communication and this coordination is single simple word for I am an awareness person. So I always tell everybody that your work start with the A, B, C, D, and A is awareness. You must think, and this coordination, like these three big Haryana, Delhi, and UP SAR has come together forward. This is something very important. It shows the unity. It shows the way of working. It shows the light, and we all are together. And this makes a difference. And discussions, we all are highly educated and skilled person. We know our talks and topics, but somehow these non-technical, non-clinical part are also very, very important. And somehow to counsel our friend and to work for our friend, and to make friendship bond grow stronger and stronger without any hatred. Thank you very much.
Thank you, ma'am. Ma'am,
Thank you.
I would like to say a few words about you. I mean, we have not met so many times physically, but I had been communicating with you many times. I'll tell you how. My center is a Foxy accredited center for advanced infertility training since 8 years. So when the time of renewal had come, that time you were the office bearer, and I had given you so much of trouble, and every time you were so nice. Whenever there was some problem, I used to call madam, madam, ye ho raha hai, wo ho raha hai. And then this, if somebody is not, like she is a member, Foxy member, but she has not paid the annual fees, so she had been rejected. So madam, she used to tell me all these things. Around first, ye dekha karo, then you register the patient, these people with their courses. And you were so nice every time. She never got, irritated, and never. Every time she used to pick the call, and I'm really thankful to you, ma'am, that time.
One thing I want to say, that today this is our elections also going on, and I'm really I'm not for anybody, but I think the election is a part and parcel of our life, and we all should think that that we are there for our friend and for our pupil. I don't want to say much, but you understand what I mean to say. So I think just keep in mind, and thank you, Aradhana. You are such a wonderful gold medal type of winner. I always see you with so many tags and here and there, so much of
I'm winner of National ISAR quiz also. I was last year ISAR winner also, quiz winner.
Yeah.
Thank you so much. Thank you. Now I take it over to, and I would invite the co-MOC for today evening, Dr. Anuradha Khar. Dr. Anuradha, I'm sure you are here. Okay, so would you like to take it up from here, and we go on to our, since we do not have Dr. Tarini here, we can we go to the panel discussion then.
Before
good evening, everyone. Good evening, everyone. Dr. Jyoti, could you continue for 5 minutes, because I'll get into the car and then I can take it. Okay. Thank you. Thank you. Welcome all. And it's a pleasure having all.
Dr. Seema, you were saying something. Sorry.
Yes, respected Dr. Sharda Jain ma'am and Dr. Renu Chug and Dr. Archana Verma, thank you so much for enlightening this session with your gracious presence. And yes, ma'am, as you said, knowledge is to be imparted, and that's the aim. And with that aim, we'll just start the session. I just wanted to personally welcome all our esteemed faculty, and thank you, chief guests and guest of honors. Remain here, please remain here to guide us wherever we are going. I mean, we want each and everyone's view regarding their practices, as you said, and we are not going to talk about the evidence. What is our experience? How are we getting it? We are going to talk about that also. Thank you so much. Over to you, Jyoti.
Yeah, thank you, Dr. Seema. And now we move on to the scientific session. We have our first panel discussion, the topic of which is fertility in PCOS women, things to be done differently, where this panel would be moderated by none other than Dr. Seema Pandey and Dr. Aradhna Gupta. And for this panel, we have experts, Dr. Abha Mazumdar ma'am and Dr. Neena Malhotra. So we have, should I go ahead with the panelists' names and details? Dr.
Yes,
Seema?
please.
Yeah,
Yes,
so
please.
we have, okay. So we have our panelists for this, Dr. Jyoti Bali, Dr. Sunita Arora, Dr. Rakhi Singh, Dr. Anshu Jindal, Dr. Poonam Lumba, Dr. Shivani Gaur, Dr. Ranjita, Dr. Divya, Dr. Anju Verma, and Dr. Ekika Singh. So just to introduce the panelists, may I have the CV slides? If we can just, I would quickly go through the CV slides of Dr. Rakhi Singh. Dr. Sunita Arora's CV, do we have? No. So Dr. Rakhi is the chairperson of Endocrinology Committee FOGSI. She is vice chairperson UP ISAR, and she is peer reviewer of the Journal of Obs and Gynae of India. She is also president of Noida Obs and Gynae Society and has multiple awards to her credit and numerous publications. She is director, Abalon Clinic, Fertility and IVF, Noida. Next, we have Dr. Anshu Jindal. Next, please. Next slide. So Dr. Anshu is a consultant obstetrician, gynec, and an IVF specialist, Jindal Hospital and Fertility Center, Meerut. She is joint treasurer UPSR and editor of the UPIAGE and member Infertility Committee FOGSI, multiple gold medals and trainings that she has done from Kiel University.
I would like to interrupt you.
Yeah.
Ma'am Abha had joined and then she has left because the long CVs were running. So she
I think we can keep
okay,
it short.
so next, ma'am, I'll cut it short. Right. So next
the
we
line
have
for each.
one line. Dr. Poonam Lumba is from Ambala. She is director Lumba Hospital, and she is also the founder chairperson of Haryana chapter of ISAR, and she is the honorary librarian ISAR 2019-2020. Next, we have Dr. Shivani. She is director SCI IVF and founder secretary of Delhi State chapter of ISAR and secretary of INSTAR. Next, we have Dr. Ranjita, who is director Medicheck group of hospitals, and she is from, I don't know where the place has not been mentioned here.
From Faridabad. She's from
Jyoti, let
please
panelists just introduce themselves in a line. That's it. Otherwise, it will be non.
We will take it in last, no, ma'am.
Only two are left now. So for the next panel, we'll do that.
She's also from Faridabad.
Continue.
Divya Kumar, she's also IVF specialist and she's from Faridabad. Next.
Dr. Anju Verma is from Gwalior.
Yeah, she's from Gwalior. She's currently, she was past secretary, MP SAR. So she has joined. Dr. Ekika, she is another fertility consultant. And She's from Mau. Yeah. Next. Anybody left? I think
Done.
we should start now.
So, good evening, my dearest, respected chief guest of honor, and my respected experts, Dr. Abha ma'am and chairpersons. Today, we are going to start this topic of polycystic ovarian syndrome women, how their conception is different than any other woman who is suffering from infertility. To co-moderate this panel with me is my friend Dr. Aradhna Gupta. And we will not talk much about what polycystic ovarian syndrome is. All of us are aware of it. And please, first question, Dr. Aradhna, are you taking or should I continue?
You continue. I just want to try to connect with Dr. Abha ma'am. No, she has
Okay.
left.
So the next to my Aradhna, there is Dr. Anshu, and I would just like to know from Dr. Anshu how our polycystic ovarian syndrome women are different than other women when it comes to treating them for infertility.
From infertility point of view, Seema?
Yes.
Yeah. So polycystic ovaries, we all know, is a heterogeneous disorder. It has, we have lean PCOS, we have obese PCOS, and there are different phenotypes in polycystic ovaries. So these women behave differently. 50% of them have an infertility issue. Other 50% have other issues which, we have to deal with. And their ovarian response can be very prolific, like they can be too much of overstimulation in some patients. Or if in obese PCOS, I've seen that if you don't give them the adequate dose, they just don't come up with follicles. So PCOS women is a big heterogeneous group, according to me.
So, Doctor, who else is there? Anybody would like to add something to this? Dr. Poonam? Dr. Poonam, you are muted.
Okay. See, PCOS, it's like since ages we are seeing women of different age groups coming to us with, big ovaries. Weight may be there, weight may not be there. Then hyperandrogenism may be there, it may not be there. But most difficult part is to make them ovulate. And with experience, we have come to the conclusion that going for early IVF in very resistant cases is not a bad option. And thanks to the different stimulation protocols and the freezing options which we have seen today, because many years back when we started earlier, it was really, really horrifying tackling women with hyperstimulation, ovarian hyperstimulation syndrome. And we have done so many ascites, pleural effusion, handling the women. And then some women, unfortunately, we had to decide to, abort them at early stages. But now the scenario has completely changed. It has become so safe in IVF also, with all the vitrification options and freeze all options. And then we have the GnRH antagonist.
We'll come to that, Dr. Poonam. Yeah, excellent answer. And the main thing I wanted to tell that these polycystic ovarian syndrome women, because of this persistent endocrinological disturbance in terms of hyperallergenemia, hyperinsulinemia, and hyperandrogenemia, their oocyte quality gets disturbed at the cytoplasmic and nuclear level. And that's the reason as per you discuss the phenotype, if as per phenotype, some take longer, and as Dr. Anshu said, few they get overstimulation in meanwhile. And even if they get stimulation, they get pregnant because of three consistent factors along with obese phenotype. They tend to miscarriage faster. Their even endometrial receptivity get disturbed and affected by these factors independently, and as well as PCOS per se. And that's why we have to be really careful when we are doing ovulation induction, and especially if we are doing it for our IVF patients. So polycystic ovarian syndrome, few will take longer like phenotype A, and that was the question I was coming next to. Does phenotype affect the plan as you are going to take whenever you are choosing your ovulation? For example, if we are talking about ovulation induction, what are all those factors do you take into consideration when you are planning your ovulation induction for a PCOS lady for non-ART cycle? And does phenotype matter in your decision? I would like to ask Dr. Anuradha Khar.
Yeah. Thank you, Dr. Seema, and good evening, everyone. Yes, definitely. See, on one hand, in PCOS, we have the lean PCOS patient, and on the other hand, extreme, we have the obese PCOS patient. Now, what is common in both the things is hyperinsulinemia leading to later insulin resistance. Now, ovulation, if we go by the guidelines, ESHRE guidelines, we have the best ovulation which we can give orally is letrozole. That's the drug of choice. But before that, there is age to be considered. Ovulation induction cycles, whether they have had the fertility, infertility time, the time since marriage, since they are trying, so how long it has been, and previous induction cycles, whether with oral ovulations, they've had ovulation or they are resistant PCOS. This is very important. And of course, we have to give them lifestyle modification, weight loss, diet, exercise, which really improves their response to this
Anuradha,
ovulation.
yes, Dr. Anshu. Is Dr. Divya or Dr. Ranjita are here?
Yeah, they are here.
Dr. Ranjita, what are those factors like you take into consideration? One is obesity, and what other factors are you looking into when you are choosing an ovulation for a patient with polycystic ovarian syndrome?
Yes. Hi, everyone. As Dr. Anuradha was telling about the insulin, hyperinsulinemia, and so many other factors, in PCO, actually, we have multiple follicles. So we have to see about the last ovulation, what they have been given, and the follicular monitoring has been done properly or not. Whether it was just a simple ovulation has been given, that is 2.5 for 5 days or 5 milligram for 5 days, or extended protocol or step up protocol, which we are using nowadays for the good FSH2, for the good recruitment cycle. Because if we don't try to recruit a good follicle, we will not be able to monitor the leading follicle. So first thing we have to keep in the mind while choosing our patients, to follow up the old records and see properly whether this patient needs which kind of protocols to be given.
Moreover, whether she's hirsute or that also makes a difference on her ovulation in status, and what response she's shown in the previous cycle. If she's not responded to ovulation, oral ovulation, then you have to go on to gonadotropins or step up protocol. So you have to see her previous response, and then only you can decide the further protocol.
Thank you, Anshu. But we were discussing two more things I wanted you people to add was AMH and AFC, along with age and phenotype we wanted to see. And this is an excellent thing that we have to look at the previous response and then we decide accordingly, as all our panelists said. I would like, has Abha ma'am joined us?
No, she has not joined. I think actually
I
she
would
has.
like to ask Sharda Jain ma'am, what is her experience? How does she find these PCOS women different in their response, in their preparation when she is taking these patients for ovulation induction, ma'am?
I think as far as the PCOS is concerned, I find, the ones who have to conceive, they conceive very fast. And the ones who do not conceive, they will give you really pain to become pregnant. Earlier, we had bad results, but since the time we have come to segmented cycles, our results are great. And I find, like you, I also believe that 50% of the battle is won if she loses at least 5% of her weight. If 5% of weight is lost, I mean, she can normalize, nothing like it. But if she loses her weight, 50% of battle is won. And then we use segmented cycle. And I think, now I can see Dr. Abha Majumdar, she'll be able to answer you very much.
Yes, welcome, ma'am. Good evening.
Good evening. Good evening.
Good evening, ma'am. Thank you very much, ma'am.
Yeah. What is your question? I just hear your
Ma'am, I
question.
was just asking that if there is a lady polycystic ovarian syndrome and you are planning ovulation induction, so what are the factors you are looking at, and are you taking her phenotype into consideration while you choose an ovulation for non-ART cycles?
Yeah, first important thing is that it's only ovulation induction which you are planning at. And so you cannot think of segmentation of a cycle when you are planning ovulation induction, because here you will induce ovulation and you will let her get pregnant on her own, or you might add an IUI, whatever your protocol is. Number two, for thinking which oral ovulogen you want to use, it is totally your preference. However, overweight women who the BMI is more than 27, maybe letrozole is a better option. Those who have a higher AMH also, because we don't want an explosive reaction of having many follicles come up on the surface. So maybe letrozole is the first line of treatment, clomiphene citrate, the second line of treatment for these women. And if they do not respond to maximum, I do not think that more than 5 milligram of letrozole or more than 100 milligram of clomiphene is in line. If they don't respond, you go to a gonadotropin cycle. This is all you could do. Metformin is a controversial drug. It can combine.
Yes.
Yeah, you could combine and you may not combine. But yes, it is good if she's overweight to combine metformin prior to starting ovulation induction, but only for the sake of ovulation, metformin may not be enough for such a woman.
So, ma'am, here comes the question to the panelists and even our experts. Like, are you still using clomiphene alone for ovulation induction, or are you segmenting your patient obese versus lean for your choice of ovulation being CC plus metformin and letrozole alone? If yes, when and where?
So as Dr. Abha Majumdar said, for obese PCOS, and my first choice is always letrozole 5 milligrams daily. And that ovarian response will let me know what I have to do in the next cycle. If I get a good response, then maybe 3 to 4 cycles of letrozole. Otherwise, I think gonadotropins give us much better results in PCOS. The low dose gonadotropin cycle.
Anyone has used combination of clomiphene and letrozole? Anyone?
That has been published in a few papers, but I don't think that is a very ideal situation or a protocol to be used in PCOS women. However, there have emerged some papers with the use of both the drugs. But I really feel that it is best to refrain yourself to a single drug, to start with a low dose in PCOS, letrozole 2.5, clomiphene 50. And if you don't get an ovulatory response, you can go up to 5 milligram of letrozole, 100 of clomiphene. You still don't get a response despite having combined it with metformin. The next step is go to gonadotropins.
Yes, ma'am. Over to you, Aradhana.
Yeah. So next is what is your protocol of choice for a woman 30 years age? Her BMI is 30, so she is obese, and duration of infertility 5 years, and predominant trait is hyperandrogenemia. So she is obese with hyperandrogenemia with a duration is like 5 years long, and she is 30 years like borderline. So what would be the protocol of choice? Let's start with someone who has not yet come into the picture. Dr. Divya, I think. Hello, Dr. Divya, are you there? Dr. Divya Kumar? Okay, then let's start with Shweta. Shweta, are you there? Shweta is panelist.
Shweta is in different panel.
Okay.
Anu
Ranjita?
or Dr.
Yeah.
can.
Ranjita?
Yeah, I can
BMI
listen.
more than 30. First thing I would, even if infertility is 5 years, I think first we should do the weight loss by diet, exercise, send her to a gym and, try to lose little bit weight. And after that, we would like to, it's not shown here whether she has had previous ovulation induction cycles. I'll assume that she has not had ovulation induction prior to coming to us. Then we can start letrozole for her. Because hyperandrogenemia, it's better for us to give letrozole. Also, we would like to do HbA1c and the sugars and all, and see if she has any borderline diabetes or diabetes. And if she has, we can start metformin for such patients. Or her OGTT is over the if she is borderline diabetic or diabetic, then we can start metformin also along with letrozole and give her one ovulation induction cycle. Probably I will start 5 mg directly, not 2.5 for her, and then monitor her accordingly for any
Dr.
ovulation.
Anuradha, this patient is saying that she cannot lose weight. Yes, ma'am. Ma'am was saying something. This patient says, I cannot lose weight. Please do something. Ma'am, you are muted.
I think if you were to ask me if I were to add something, I think Dr. Abha Majumdar cannot be heard, is that we need to control
muted,
her
actually.
BMI, control her if she has IGT or she has.
Dr. Anshu, she is saying that she cannot use her weight anymore.
That is
Please
a very
do
common
something.
scenario in all our private practice also, that most of the patients claim they will lose weight, but they're not able to lose weight. So considering she has a high BMI, besides weight loss, we can start her on metformin. She has hyperandrogenemia. We can give her anti-androgens in the cycle prior to the stimulation cycle, not in the cycle in which we will stimulate her. So basically, prepare grounds first for 2 to 3 months, make her aware of her problem, and then probably in the next cycle, when we are stimulating her, start her on gonadotrophins and stop her anti-androgens, and metformin can continue in the ovulation induction cycle as well.
Dr. Anju, are you there?
Anju is there now.
Yeah, Dr. Anju, could you add something about her weight loss? What drugs you would like to give to help her out, because she is not able to control her diet, or she can't change the lifestyle, or she's not, she's saying I can't lose my weight. Dr. Anju, please unmute. Dr. Anju Verma.
Actually, metformin is the chief drug to treat the overweight patient, as well as also there is causes of hyperinsulinemia. Hyperinsulinemia produce hyperandrogenemia. So metformin in full doses, I think I can say 1.5 to 2 gram per day. And we can also add Decadron, 0.25 to 0.5 milligram cycle preceding to the ovulation induction. We can say 10 days prior to starting of ovulation induction to drop this level of the androgen. I usually use Decadron.
Decadron means steroid?
Decadron not for weight loss, Dr.
No, not for weight loss, but for hyperandrogenemia.
Now we have
So,
some drugs like orlistat and even semaglutide, and these drugs are also into the picture. So we can, I think, try till she is not going for the conceivement. So like before that, but
Dr.
she has to, yeah,
Dr. Aradhana and Dr. Anju,
Yeah.
this patient does not want to lose weight. She wants to get pregnant on this BMI only. Our concern is hyperandrogenemia and BMI 30 with ovulation induction. As ma'am Sharda Jain said that we cannot use steroid here for weight loss. Even for hyperandrogenemia, why will we go for steroid when we do not know the source in PCOS? It is mostly more than 80% source is ovarian. There are more than 80, more than 90% source of hyperandrogenemia is our ovarian stream, and rest is from adrenals and peripheral tissue. So why would we give previously the steroid? There's no need. If we have to go, we can go with third generation, fourth generation oral contraceptive pills. Ma'am Abha Majumdar was saying something. She was muted. So ma'am, please unmute and give your opinion, ma'am.
I think what is very important is that rule out congenital adrenal hyperplasia of delayed onset. And if the 17-hydroxyprogesterone level is normal, then steroids have absolutely no role in this patient. What is her AMH is very important. Women who have very high AMH along with obesity of this degree that the BMI is 30, they respond to higher doses of gonadotropins. We have to go escalating the gonadotropin if she hasn't responded to oral ovulogens. And for her, both the drugs are equal, whether you use letrozole or clomiphene, because high AMH also inhibits the recruitment of a follicle, as does her high weight. So we cannot ask a woman who's come after 5 years of infertility to wait for weight loss at all, even though lifestyle changes are very important to address to the patient, to bring into her notice that if she gets pregnant on this weight, pregnancy complications are more common. But her infertility can be treated at this weight or lower weight, both equally. But her pregnancy, diabetes, hypertension, miscarriage, all is higher in a woman of this weight rather than just getting pregnant. So I don't think that hyperandrogenemia has anything to do over here, except maybe may cause resistance to oral ovulogens. Hence, we can use them first. If she doesn't respond or she has already taken them before, then this is a case where straight away gonadotropins need to be used in an escalating dose.
So thank you, ma'am. So in this case, that trick was that hyperandrogenemia with obese PCOS, as we keep reading and look at for general obstetrician and gynecologist who is not using gonadotropin, letrozole is drug of choice. You can add metformin here, and otherwise you can use CC plus metformin as well, and that does very good work in obese PCOS when it comes for ovulation induction. And as ma'am said, hyperandrogenemia has not to be corrected, but she has to be told about the lifestyle measures and the consequences in her antenatal and perinatal period. So coming to the next question, Dr. Aradhana.
Yeah. So she is the 32 years previous life.
No, this one is the main slide.
Oh, Allah. Okay. So, what is the protocol of choice for a lean PCO with serum AMH 7.8 nanogram per deciliter? We can start with Dr. Anju Verma.
Yeah. Because AMH is so high, so we should be very cautious because these patients maybe land up into hyperstimulation because their lean PCOS is very prone to go in hyperstimulation. If she wants only just simple ovulation induction, letrozole is the best drug. Simple.
If it doesn't work, because with this high AMH, letrozole might not work, then we have to think of low dose gonadotropin.
Low dose FSH.
Yeah, so maybe even 50
That is a
recon.
double-edged sword again because she may hyperstimulate or she may I mean,
Yeah, they are more prone to
Very,
hyperstimulation.
very chronic low
Cautious.
dose FSH, or we can start with very low dose also.
I think we can try with ovulation first if she will not
So,
respond.
I think letrozole
Actually,
is
the
the
problem
best.
with
Dr.
oral.
Poolam Lumba.
Yeah, actually, see,
Ma'am,
all,
you said.
all women with higher AMH more than 5, they tend to go in for ovarian hyperstimulation. So first point is we must counsel them, and I can start with clomiphene citrate also for her, just to try if she has not had any oral drug for ovulation induction. And gonadotropin will be my second line of choice.
Is some particular reason behind using clomiphene citrate for this patient, madam?
No, not particular letrozole or clomiphene, but both the drugs I can use.
So how many of you are still using clomiphene citrate for your PCOS patient?
Madam, I am using. It's not
I am
totally
using.
obsolete that I am not using clomiphene. I am using both clomiphene and letrozole.
No, I'm also using both. Yeah, both clomiphene and letrozole.
I
And
mean, do you have
definitely
some selected
letrozole is
category
the
for
first drug of choice.
clomiphene?
For
I have one point to make, that I would give letrozole because of the monofollicular response. She's a lean PCO. I have seen even, with CC, I have done torsion oophorectomy for these patients in second month or third month of pregnancy. I had a patient. So she was induced with the clomiphene outside, and she had a OHSS, and her ovarian torsion happened. I would be very, very cautious about this patient. She's lean, she can flare up. I'll use letrozole. I'll start with small dose, go on to high dose, and then add the gonadotropin in a slow manner.
And also
Absolutely.
with clomiphene and second to third cycle, there is decrease in the endometrial thickness. So we can try only one cycle of clomiphene.
No,
So,
we start with very small dose, not more than 50 milligram.
Yeah.
So these are the women who used to come with triplets and quadruplets, even with oral ovulations.
ovulations,
And
yes.
message here we wanted to give was that the drug of choice for lean PCOS is letrozole, not only because, as Dr. Anuradha said, that it gives monofollicular growth, the live birth rate and clinical pregnancy rate is also better. And whenever we are doing oral ovulation induction, our concern is not ovarian hyperstimulation syndrome. Here we are wanting to prevent multi-fetal gestation, that a woman should be enjoying her pregnancy. I would like to listen to our experts, what is their opinion.
Like to have Madam Abha's word here.
Abha ma'am, we want to hear
Abha ma'am,
from you.
Sharda Jain ma'am.
So whether I'm muted or not. Am I muted?
No, ma'am, you can
Ma'am,
be
you are
heard.
being muted in between.
You can be heard.
Hello.
Yeah, ma'am, please unmute.
As far as this lean PCOS is concerned, I'm one for using only letrozole in such patients. And I
Yes,
find,
ma'am, me
in
too.
case if they do not work, then switch over to gonadotropin cycle. That's it.
Same here, ma'am. Ma'am, Abha was saying something, ma'am.
Yeah. Can you hear me now?
Yeah.
Yes, ma'am.
Yeah. See, if it is the first cycle and clomiphene is not banned from being used, clomiphene is still a very good drug, and you can give a dose of 100 milligram, but only very, very carefully in a PCOS. So letrozole is definitely a good drug. It also may cause 2 follicles, and it may lead to pregnancy with both the follicles having released a oocyte each, but it is rare. So letrozole is safer in these women. Clomiphene, if started to be used, it should be used in 50 milligrams. However, whether it is letrozole, gonadotropin, or clomiphene, if you have a multifollicular response, with all the drugs, you would want to do one ultrasound on day 12, 13 to see what is the response. And if it is a multifollicular response, sexual intercourse should be avoided 100%. And if they have had a sexual intercourse where they did not realize that they are going to have a multifollicular response, then a pregnancy should be avoided. Like Dr. Anuradha said, that you could have a torsion of an ovary. It's a rare occurrence, maybe in 1,000 one case may have, but that rare occurrence also needs to be prevented. So definitely I agree, letrozole is a safer drug in terms of OHSS, in terms of multiple pregnancy happening, but clomiphene should not be abandoned because it is still a very good drug to be used in PCOS.
Thank you, ma'am. So coming to the next question, this patient is 32 years old, para 0, 2 abortions, going for ovulation induction. Here, my question to Dr. Ranjita is, what are the things you will be doing beforehand? By doing beforehand, I mean to say pre-pregnancy optimization. So before starting any ovulation induction, what are the things you will be looking at into their investigation additional, and what are the things apart from folic acid, vitamin D you will be giving or advising her to take?
Yeah, as this lady, she has got 2 previous abortions. So I'll be going for the local examination as well as systemic examination in manners of blood. So for this, we have to look for the any cervical incompetency, any uterine factor if she has. So these 2 local factors we have to look into that, because cervical incompetence can also lead to which kind of abortion you have not stated. So definitely I will go in a broad manner about the cervical factor and uterine factor as a septum or any kind of fibroid, intramural fibroid or any kind of polyp. So these 2 factors I will see locally. And about the blood investigation, I will try to do this APLA, and there are so many test things about the first trimester abortion screening. We have to look into that manner also to rule out the cause, as well as chromosomal study of both the partners.
Dr. Ranjita, let's stick to, I mean, we are doing PCOS. Yeah, all those bad obstetric history and RPL panels you will be doing. I want to understand how many of you would like to start metformin beforehand for this patient and adding vitamin D along with that, or is anyone doing hyper? If you are doing all those panels, are you going to do hyperhomocystinemia as well?
Yes, I will definitely do serum vitamin D3 as well as serum vitamin B12 and level of homocysteine to check for the.
Okay, ma'am is trying to speak. I think she is muted again. Abha ma'am.
Abha ma'am, please unmute yourself.
In meanwhile, how many of my panelists will give?
We have to first see, Dr. Seema, that this patient has had abortions because of polycystic ovaries. We need to see that. She doesn't have any dyslipidemias. She doesn't have any IGT, which means intolerant glucose levels are absolutely normal, fasting and PP both. And her obesity is that she's not obese. All these things need to see, we need to look, and vitamin D and B12 we are giving to most of our patients nowadays so that she has a good heady start before she starts a pregnancy. Tell her that she has to, her weight gain should not be throughout the pregnancy, should not be more than 10 to 12 kgs. So she has to be a little conscious of her diet as well throughout the pregnancy.
Yes, that's what I wanted to know. Polycystic ovarian syndrome patient, they tend to miscarry. Apart from, take it for granted that other things are normal, other causes. When we are talking about polycystic ovarian syndrome, her sugar levels, and as Anshu said that if she is obese, then her BMI, anything BMI more than 23 as 24 has to be taken for lipid profile testing. And is ma'am speaking something? We cannot hear her. Ma'am, please unmute, ma'am.
And even her thyroid status, I think we need to see before
Yes,
she becomes
yes.
pregnant. Hmm.
Yes, and metformin or any insulin sensitizer,
Can
do
be
you people
started.
add till ma'am is not being able to unmute herself? Ma'am Sharda Jain, what is your take? Do you give metformin to these patients before starting ovulation induction? And if do, then for how long before starting?
See, earlier I used to see that only when there is an abnormal glucose tolerance test in an obese patient, then only I used to get started. But I think, things have changed now, and I find whenever there is BMI is more than 27, I as a policy definitely start metformin along with the ovulators.
Ma'am,
I don't
even
like
for
IVF.
these,
I do not wait for 2 months, for a month or so. But in this I can start if I find she's an obese.
and I do add metformin to these patients usually to who are having bad obstetric history, though the evidence is very conflicting. Our Cochrane is always confused, and metformin is such kind of drug that sometimes it becomes super favorite of our researchers, and then a time comes then they just start discarding. But if you believe that polycystic ovarian syndrome is a metabolic disease with underlying ovarian defect, then you have to believe in hyperinsulinemia, insulin resistance, and metformin. And it's a beautiful drug. Any of our panelists want to add something, or Aradhana will take the next question?
Also, Dr. Seema, what is happening is generally random blood sugars are being done, not even in peripheral clinics, not even fasting or postprandial. So probably HbA1c is a good test to do in such patients because we get the last 3 months what's happening to her sugars. So I always do a HbA1c, not
That's
only
what
for
Anshu
PCOS.
said, yes.
Yeah. Yeah, HbA1c should be included in the testing, and
Yes,
of
it
course
was
OGTT.
included. And let's
And
not.
OGTT.
I would request my panelists not to repeat the topics which has already been covered so that we can
I would
cover
like
more
to add, Dr.
questions.
Seema, I would like to add few more things.
Abha is here. Madam Abha is here.
Abha ma'am, you were saying something.
No, I wasn't saying anything. I'm quite happy at what discussions you are having, and it is
Okay, I
important.
think you were talking, so that's why.
Yeah. See, another thing is when there've been 2 miscarriages, please don't attribute them to PCOS. Find out reasons for miscarriages as you would do in a PCOS or a non-PCOS woman. And now 2 miscarriages also, according to the ESHRI and the ASRM guidelines, invite all investigations which are relevant. RCOG still wants to do them after 3 miscarriages. So I think karyotyping of the parents, the APLA screening after 3 months of a miscarriage are 2 important investigations, and ruling out a Mullerian defect or a synechia as a result of any surgical intervention done during the miscarriage as suction evacuation DNC has to be ruled out. If these 3 things are ruled out, and we can surely, like Anuradha said, do a HbA1c to make sure that her blood sugars in the last 3 months were normal, then we should go ahead with another stimulation and treat her as unexplained recurrent miscarriage first trimester.
So here my question to the experts was, ma'am, since it has come into category of recurrent pregnancy loss along with polycystic ovarian syndrome, are you people doing hyperhomocystinemia testing or anything specific, as it has been seen that it has been correlated, associated more with RPL cases and PCOS?
Bebu, hyperhomocystinemia is more with your favorite drugs prolonged use. That is metformin, if used for a long time, it can lead to hyperhomocystinemia. And hence, if you find hyperhomocystinemia, then giving folinic acid would be a good option instead of folic acid. And maybe if her MTHFR gene mutation is also positive, the homozygous type, not the heterozygous, then low molecular weight heparin may quite be in order if she gets pregnant.
As Dr. Ranjita said.
Methyl folate.
So,
more
yes.
aspect in such patients, these are already under, psychologically they are like depressive state, PCO patients, and over to it, if they have two like pregnancy losses. So like with RPL with PCO, that would increase the anxiety level and maybe depression. So like psychological, tender loving care, TLC, that is very important, I think, aspect. Maybe she will have she will carry third pregnancy without any, this issue. So I
Yeah,
think
TLC after ruling out a substantial cause for her RPL is very important. But you have to rule out the causes first before rendering only TLC to her.
So the answer of the question was basically sugar, lipid profile, thyroid, APLA profile to be ruled out, and folinic acid apart from plain folic acid along with vitamin D and whatever you want to do. Plus I give insulin sensitizer to my RPL patients where I don't find anything if their BMI is even thoda sa bhi over 25. So that is the thing we wanted to discuss. Over to you. And one more thing, as Dr. Ma'am Abha said, that MTHFR gene homozygous. So if you find it in female partner, then your male partner testing is mandatory to move further ahead. And as Dr. Ranjita was saying, that latest thing is the CMA or karyotype of the conceptus, and then we are going other way around, going to the parents for karyotype and things that should be taken into consideration to rule out all the other causes. Over to you, Aradhna.
So in clomiphene or letrozole non-responders, you have given cycles and they are not responding. What else can you do to improve the pregnancy rate and shorten the duration? I think we have little bit discussed about it in previous cases. So just to highlight a few important points, because we are running short of time, we can start with Dr. Anshu Jindal.
Yeah. So the first thing that comes to my mind is that in patients who have not responded to letrozole or to clomiphene, which are actually a very big bunch of patients who do not respond to the oral ovulogents, they might ovulate on them, but pregnancy doesn't seem to be happening. So my first thing is to put them onto gonadotrophins. Low dose gonadotrophins, I think, give us much better results in giving us a better ovulation, better pregnancy rates. Almost twice you can get 2 times better pregnancy rates can be achieved. If she has hyperprolactinemia, should be ruled out because almost 20-25% of the patients of PCOS can have hyperprolactinemia. So if that is so, you have to treat them that also to decrease the time to pregnancy. Look at the thyroid status, that it is absolutely normal. If it's
Dr.
not,
Anshu, Dr. Anshu, we are just talking about CC non-responder patients. So if they are
metformin
ovulating
metformin
and not
obese,
getting pregnant, you added gonadotropin, and then you just let's keep
Gabaline
from
if
there.
hyperprolactinemia, and metformin if she is obese, PCOS, or she has IGT is high.
My question is, can you introduce IUI at this stage? Your patient is ovulating with letrozole or CC but not getting pregnant.
Yes,
I think CC
yeah,
failure is
you can.
the category
Absolutely.
where IUI can be
Can be,
introduced at this level, and letrozole or CC plus metformin can be given. The best would be gonadotropin plus IUI, but if you cannot, you should be going with anything insulin sensitizer. LOD has no role because it is very short lasting, and CC plus metformin or gonadotropin or letrozole results are almost equal to what LOD gives. Now we'll be having one-liners only. This one, Aradhna.
Yeah. So now next is a lean
And
20-year old PCO.
one by one, and 1 or 2 liner. We have 4-5 questions and 7-8 minutes.
Married for 3 years. She's young PCO and married for 3 years, had 3 to 5 cycles of CC already and letrozole. Still anovulatory. So she is like resistant to all these things and not ready for a costlier treatment like gonadotropin, maybe IVF, and frequent visits. The next treatment of choice, what do you think? What else we can do for them if they don't want to go for a high doses of gonadotropins or IVF or
Dr. Anju, Dr.
Yeah.
Anju, where is
I
she?
think patient who are not want to go for higher costly treatment, we can add extended letrozole program, extended letrozole for 10 days. Or we can also do a step-up protocol of letrozole, because I think letrozole not responding is just for the 5 days. I think it is written like that. Otherwise, we can also offer the extended letrozole program.
anything
Suppose
else?
she's already taken that also.
Extended also. Then
That
there is
Yes,
between
step up,
must be
extended everything.
gonadotropin. Gonadotropin is the only choice, I
She's
think.
not
Because
ready
she's
to.
not
She's
ready
not
for the
ready.
costly treatment. What is
So
the choice?
just do the FSH LH level. If LH is high, go the OC pills for 2 to 3 months, then start again stimulation.
Anybody can add something? I mean, anything else we can do for her?
You can add
Anuradha.
metformin in such patients. Add metformin for such patients.
That has already
Yes.
been added.
No, it is not
Nairobi,
added.
you can
It
do
is
not
not
added.
added.
Nairobi,
Not added.
if it is less expensive, if you can call it
Yeah,
less expensive
Seema.
than LOD.
Ranjita, and
Hello.
Divya is not here. No, Ranjita,
Yeah.
will you consider her for laparoscopic ovarian drilling?
Yeah,
Hello.
you can consider.
Yeah,
Seema.
What precaution
Yes,
would you
yes,
take for taking before taking her for LOD?
Yeah, Seema.
yes.
But she is not ready for
Hello.
costly treatment. LOD is also costly.
Yeah.
That's true. I
Hello.
would agree.
Laparoscopic is also not a simple thing.
Hello.
More
Laparoscopic
expensive
is
than
cheaper
gonadotropins.
than adding few gonadotropin
Yeah,
injections.
cheaper.
No, why don't we give her a break for 3-4 cycles? Give her
4
OCP,
cycles, yeah. And then
Yes,
just down the
Dr.
LH level
Poonam,
down.
yes.
and then again start.
LH has no role in ovulation induction cycles or super ovulation or COS
No,
cycles.
we
We
have
are not
stopped doing
looking
FSH
at.
and LH for PCO.
See, I
So,
would leave her
We
for
can
2-3
give,
cycles.
we can see
I will give her a break.
hyperandrogenemia still have. We should address
the
the
trick was,
hyperandrogenemia in such patients.
I agree
We
with
can
Dr.
give
Poonam, we can leave her for 3 cycles. Does anyone disagree?
She's
So
young.
she's
Dr.
not going to be
Shada
helped.
ma'am, Dr. Abha ma'am, what will you do in this patient?
Dr. Seema, she's not going to
What
be
is
helped
going
by
to
if
be?
left alone. I doubt if she will be helped much.
No, it was a joke.
Hmm.
I'm just saying. Dr. Abha ma'am, Dr. Sharda Jain ma'am. Are they
Can you
there?
hear me? I can hardly hear you. I don't
Yeah.
know why. Can you hear me?
Yeah, ma'am. we
Yes,
can-
ma'am. Yes, ma'am.
I don't think that we need to give. What is your main concern about this question? I'm losing out on it because I had calls, patients consultation calls in between, which I had told were
Okay, ma'am.
started. Just tell me what is the main question over here?
She is not ovulating with letrozole and CC, and she's 25 years, 3 years married. She doesn't want any kind of costly treatment and frequent visits.
Okay,
So
if she
what
doesn't
should
want
we
any
do?
costly treatment, frequent visits, even a laparoscopic ovarian drilling is costly in today's world.
Yeah.
So we would have to maybe do that if she's not ovulating with clomiphene and with letrozole, both the drugs in the highest dose, which is recommended, which is 100 milligrams of clomiphene a day and 5 milligrams of letrozole a day. And she is lean. Even adding metformin might help her, not help her. So if she's not ready, you can give her metformin, try again. Maybe you can give her a higher dose of clomiphene. If she's not ovulated with 100, give her 150, even though it's like the highest dose recommended is 100 now, but 150 was used in the past. If that doesn't help, then you convince her for drilling in a private setup. Drilling will also cost her a lot. So this is all what
This
is in my
question,
mind if she's not
And
ready
what
for
is your take on
gonadotropin or
Ma'am
myelinoprostol?
Shard,
something.
yes, ma'am. Ma'am Sharda Jain was saying something? No. Ma'am, the question was, yes, we used to be told that patient who does not want to spend on gonadotropin and IVF. This question was basically for this lady is 25 years, only 3 years married. So she is a lean PCOS, not able to afford IVF and gonadotropin. If her hormones are deranged too, she is the could be taken for LOD after proper counseling. Said about perioperative complications future decrease ovarian reserve. That was the main thing, that lean PCOS with high LH and high FSH. I welcome my teacher and mentor, Professor Dr. Anuradha Khanna. She has joined us
Hello.
recently. So
Namaskar.
now
Seema,
one-liners
just
from
evening, ma'am.
welcome,
just a
ma'am.
thing.
Namaste, ma'am.
I'm
Yeah,
good
please
evening.
ask to Dr. Mahavha
Yes, ma'am.
Majumdar, can we have both letrozole and clomiphene together in such cases
She
to
is
have low
No, I
blood?
have never
Ma'am,
used, and I have no experience with using both the
Ma'am
drugs
has
together.
already told that.
yeah, that has been
There
done.
have been
So
papers, one or
now,
two papers which appeared, which were not very well randomized, and I do not have any personal experience with both the drugs together. I do not think it's logical to use, so I've never used it. But yes, if you have
so
used it and you've got results, you can definitely go ahead. I would want to either counsel the patient for ovarian drilling if she cannot go for anything, or a gonadotropin treatment. But yes, gonadotropin treatment and drilling both are expensive in today's world in the private setup. So maybe give her metformin and try with a higher dose of clomiphene
Ma'am, now we have a
or
yes, ma'am.
multiple
letrozole.
file
I
of
tell the patient that you cannot choose your protocol. When these patients come up with such things, I tell them you cannot choose the treatment. You have to
Yes,
go by
yes,
what
ma'am.
we tell
You can tell them, but you have to look at the financial constraints also. I have seen patients
Because
who
we
are
already have
truly
6:30. Yes, yes, ma'am.
Okay, so next question is your take on routine luteal phase support in PCO women with ovulation induction. If you are inducing
One
this,
line, one
and one
liner.
line, and if you are using, then what you are using? That is that too, and doses.
In one
So
line. Yes.
yes or no, and if
Yeah.
yes, then what medicine, which one, and in what dose?
Yeah, with clomiphene and letrozole, if the endometrium is good, if everything is looking good, then you can even skip onto the luteal phase support. It is not mandatory to give luteal phase support, but in a gonadotropin cycle, I always support the luteal phase with micronized progesterone in the dose of 300 micrograms twice in a day for next 15 days during her entire luteal phase cycle. Only in patients, sometimes I do combine it with Defeston. Otherwise, this is my normal protocol.
Next, Dr. Ranjita.
Yeah,
I'm looking.
as this is a PCO patient, that means she has got her pregnancy with effort. So we should not leave her alone without giving luteal phase support. I would like to give dydrogesterone 10 milligrams in a tedious dose, because sometimes we have seen the PCO patient, they need immunomodulator, and dydrogesterone has got its very good effect as the immunomodulator. So, and as well as like it is a progesterone also, which is orally very stable, and patient can take the doses in a very easy way.
Poonam ma'am, what is your choice of in such cases?
Yeah, actually, if sometimes if I'm giving clomiphene or letrozole, my treatment is individualized. Sometimes we add on the progesterones. Defeston, most of the times we are adding 10 milligram 8 hourly, and in like in GnRH, sorry, FSH cycles, gonadotropin cycles, progesterone. Geston, either injectable or vaginal progesterones.
Dr. Anju?
As Dr. Ranjita has correctly said, in PCOS we have difficult ovulation and we got the ovulation. So I personally feel that we should give luteal support. In many cases, clomiphene citrate also causes LPD. So better to
I
give
think,
progesterone
yes.
or either Defeston. Both can be used.
Anshu, quickly, and Anuradha, then we have to go to next question.
Yes, I will
Yeah.
leave the
Can I leave the session now? Can I leave the session now?
Yes, I will.
Ma'am,
Ma'am,
please,
please
one
leave your comment
question
first.
can answer. Do
Ma'am,
you
please
use
your
luteal phase routinely or not?
yeah, ma'am. Please comment on it. We need your
Not in letrozole and clomiphene cycles, never. In gonadotropin cycles, always, and always it is a vaginal progesterone. I don't use oral micronized progesterone, nor do I use Defeston. So this is my own belief, but I think you can use otherwise, because these are all progesterone producing regimes, and hence Dufaston could be used, because I feel that Dufaston, for me, in IVF, nobody ever uses Dufaston alone as luteal support. They use it always with micronized progesterone, whether it is injectable, oral, or vaginal. I like to use vaginal progesterone. That is my take on it. And with this, I would
Thank you,
want your
ma'am.
permission to leave the panel.
Thank you, ma'am. Thank you so much for being here.
Ma'am, we are really
And
thankful you have accepted our invitation.
So
Thank you.
now coming
Yeah,
to the
I
IVF.
use
Un-
vaginal progesterone, 200
So
BD,
coming
that's
to
400.
next
Yeah.
question, for quick one-liners, please. PPOS versus antagonist protocol for PCOS phenotype A and B, and why? How many of you are using progesterone primed stimulation for PCOS patient? Any one of you?
I'm using antagonist. I'm not using PPOS.
Okay.
Anyone is-
Anyone?
I am using.
So majority of us are using antagonists.
Antagonist.
Even I use lot of PPOS for my polycystic ovarian syndrome patients, though evidence is not that robust, but it is good enough to say that LH control is better when we are starting our progesterone from day 2 of the cycle. So, but people who are using antagonists, they have the advantage of doing a fresh cycle transfer if things are under proper control. So we are not losing on the cycle. So for all the viewers, the protocol of choice yet is antagonist protocol with segmented IVF cycle and freeze-all. Fine. So trigger of choice for polycystic ovarian syndrome, 15 to 20 follicles each side. LH is more than 3,000 picogram. E2 is more than 3,000 picogram per ml. LH is 0.5. One by one. And one word.
Agonist trigger.
Along with agonist, I think we must add some
No,
SCG
I'll
also,
give
because LH
agonist
is very
trigger.
low.
Agonist trigger.
Agonist trigger, and sometimes I've tried dual trigger also.
Dual trigger.
Oh, no, there is a catch. That's why I'm asking you guys.
Actually, LH is very low, 0.5. Along with analog, we should give a slight amount of the SCG also.
I think dual trigger should be given for such patient.
These patients will not respond to plain agonist trigger if your LH is less than 1 or 1.5. So whenever you are getting your LH less than 1.5, please make it a dual trigger. Though SCG quantity you keep very slow. Freeze all is mandatory, because this patient might be going into certain level of primary ovarian
What dose of
hyperstimulation.
HCG and which
SCG sliding scale from 1,000 to 2,000, not more than that. 1,000 or 1,500 we don't get. So the message through this question was that you have to look at your LH level before deciding your trigger, even in polycystic ovarian syndrome patient, and every patient cannot be kept only on an agonist trigger, because these are the patient where when you do the cycle and you don't get follicles and you think it is empty follicle syndrome, it is not.
Very rare.
So Aradhna.
Yeah, so freeze all versus individualistic, fresh and freeze protocol in PCOS. What is your take?
See, in
कौन fresh करता है और कौन सिर्फ freeze all करता है?
Yeah.
See, it has to be individualized, because fresh transfers in PCOS we are doing if the patient is absolutely fine, not in hyperstimulation. If her ovaries are looking okay, then you can do a fresh transfer also, but not more than 1 or maximum 2. Actually, ideally, it should be just single embryo transfer. And if there is any signs of OHSS, or if the ovaries are looking big and hyperstimulation is on the cards, then you should always freeze all.
You leave the patient open and call on the day of the transfer and then see the ovaries, right?
Yeah, absolutely. Measure the size, measure the ovarian size, see the number of follicles.
What is your trigger that time? Na? You must be giving the dual trigger or something.
It depends upon the
Yes,
trigger.
very good question. Ranjita, what are you doing? Dr. Poonam, what are you doing?
See,
freeze
Yeah,
all till
mine
in
is all individualized approach, but most of the times I'm seen recently patients who were not having any indication of going into HSS after fresh transfers, they had severe hyperstimulation syndrome with ascites. Although the ovaries were not polycystic, the MH was with normal, like less than 4. So now I'm become very cautious and trying to, counsel them for freeze all options, even if the number of follicles is maybe 8 to 10 also.
So, ma'am, that
Because two,
decision
three
might have taken
patients,
during the trigger
huh,
of that time, no?
I don't know. There was no
That's
indication
secondary
of
OHSS, Dr.
OHSS.
Lumba. That is secondary OHSS. When the conception
Yeah,
happens, the
yeah, it
HCG
has
secreted
happened.
by the embryo, that causes secondary OHSS.
Yes. So
Yeah.
that is why it's like it's time to counsel the patient. So whatever choice they take. But
Okay.
definitely we have started counseling for freeze all
We'll cut
option.
it short. Yes. So it
Yeah.
is
Freeze
it
all.
should be
For me, freeze all.
individualistic, but ideally in PCOS you should believe in freeze all, because you cannot rule out secondary OHSS.
Segmentation is the
So
choice.
with this, thank you so much, and I would like to thank my experts, Dr. Abha Sinha ma'am, Dr. Sharda Jain ma'am, and my co-moderator, Dr. Aradhana. We did not coordinate at all. We are just coordinating here.
Yeah.
And my esteemed panelists who were just awesome. And thank you so much, Jyoti, for continuing this program in such a
Thank you,
wonderful
Dr.
manner.
Sinha.
Over to
Very,
you.
very good questions.
And I must hear from our chairpersons what was their opinion about it.
Thank you. Thank you so much. Lovely discussion.
Thank you, everyone. Thank you, all the guest of honors, chairpersons, Dr. Seema, Dr. Jyoti, Dr. Aradhana. It was a wonderful, enlightening session. And thank you so much for inviting me.
Thank you, everyone,
Thank you.
for
And we move on. I think we move on, Dr.
Right,
Seema.
chairpersons are saying something.
Chairpersons, Dr. Neelam Gupta, Dr. Sujata, and Dr. Archana
No, Jyoti.
Sharma.
No, Jyoti.
They were there for the
Chairperson from
panel,
the
no? They were the
chairperson from the previous panel. They were saying something. Please, we want their opinion too in few words.
Okay. So the chairpersons, if anybody I'm a little confused because chairpersons
We
for the
can't see
panel were
everyone.
Dr. Neelam Gupta, Dr. Sujata, and Dr. Archana Sharma.
Dr. Neelam Gupta
Oh.
has joined, I think. Dr.
So,
Neelam Gupta, could you say a few
Neelam,
words?
yeah, I can see Dr. Neelam there.
Dr. Neelam, please unmute yourself and say a few words.
She is there, but she's not visible.
Okay, let's go ahead. We'll talk to them later
Yeah,
on.
we don't have
Jyoti,
Dr.
move on.
Sujata and Dr. Archana also I cannot see.
Dr. Archana Verma left, actually.
Jyoti,
She has
No,
written
Dr.
in chat.
Archana Sharma.
We should
Dr.
start
Archana
Sharma.
Sharma. Yeah.
Then
So
start
now-
next panel. Yeah.
So yeah, so
Let's
we
announce next
move
session.
on to the next session after a wonderful, very, very great, very practical discussion that we had in this OHS, the PCO women. So we come on to another very mind-boggling discussion on the troubleshooting in ART lab. So for this, we are taking both clinician and the embryologist perspective. And for this, we have moderators, Dr. Charudha Joshi and Dr. Ved Prakash. And the panel experts, we have Dr. Sunil Jindal and Dr. Rajul Tyagi. So moving on to our panelists, we have, okay, so we one-liner for our moderators. Dr. Charudha is PG, Postgraduate Life Sciences and past president of ACE. Next, please. Dr. Ved Prakash is a clinical embryologist, scientific director, Sperm Life Advanced Embryology Lab, Delhi, and worked also as a lab director at South End. Then we have our expert, Dr. Sunil Jindal, a scientific director and an endo-laparosurgeon and male infertility specialist, Jindal Hospital and Madhu Jindal Memorial, and author of various books on male infertility. And then moving on to our next expert, Dr. Rajul Tyagi, who is a director of the ART unit, Javitri Hospital and Test Tube Baby Center, Lucknow, and a president and vice president of various associations in Lucknow. Coming on next are our panelists, Dr. Sarapreet, Dr. Y.S. Verma, Dr. Amog Chinmote, Dr. Manjeet Mehta, Dr. Rushika, Dr. Shweta Kaul Jha, and Dr. Gunjan Gupta. So panel, can I have the slides? Yeah. So Dr. Sarapreet Singh is a ASHRAE certified senior clinical embryologist at Artemis Health Institute, and is a champion of ESAR award at the ESAR conference 2020. Next, Dr. Y.S. Verma. He's chairperson MP chapter ESAR, and he's the director embryologist, Dr. Verma Hospital and Fertility Center, Gwalior. Next, we have Dr. Amog Chimote, who's medical director, Vasundhara Fertility Center, Nagpur, Maharashtra. Next, we have Dr. Manjeet Mehta. Though not an embryologist, she's a genetist, and we will have some different insights from our genetist from Mumbai, who's director of the Genomics Life Genogenomics Lab, Mumbai. Next, we have Dr. Rushika Mistry, embryologist at Leelavati, Mumbai. And next, but yes, Dr. Shweta Kaul Jha, who's director, Nirma Women Care Hospital. She is from Indore. Then we have Dr. Gunjan Gupta, who's founder of the Gunjan IVF World, Delhi, Ghaziabad, Meerut, and Noida. So, and for the chairpersons for this panel, we have Dr. Anuradha Khanna, ma'am. Yeah, and Dr. Anupma Sethi Arora and Dr. Rakhi Malhotra. This can I have CV of Dr. Anuradha, ma'am? Ma'am is ex-HOD Obs and Gynae Department, BHU Varanasi, and she is president of the UP chapter OBGY 21 to 24. Ma'am has various accolades to her credit, and she is an amazing teacher. Next, we have Dr. Anupma Sethi Arora. She's from Sonipat, and she is a keen teacher of laparoscopy and runs many courses there in Sonipat. Next, we have Dr. Rakhi, who is the secretary of Haryana ESAR chapter, and she is director AS Fertility and Maternity, Rohtak, Haryana, and also a joint secretary, the secretary presently of the Haryana ESAR chapter. So
Dr. Jyoti, do we have Dr.
moderators.
Do we have Madam Tarni? Tarni is there?
Dr. Tarini was there, I think, initially. Now she's not to be seen. I think she was in the previous.
Dr. Tarini was our guest of honor. We could see her.
Yeah, initially, in between when we had started, I think she had joined for some time. So we will see if she can rejoin. Till that time, over to the moderators to start this wonderful panel.
Very good evening to everyone, and thank you societies like Haryana and UP chapter and Seema madam and everyone to give me this opportunity. Me and Dr. Ved will be moderating this panel, and I can see Dr. Jindal, a very good friend of mine, is there as an expert panel. So madam and sir will be there to help us in between. So basically this this panel discussion is more of an interactive kind of discussion, where I have selected few case scenarios where we will go for the opinion of our expert panelists. Dr. Ved Prakash is there?
I am there.
Okay. So, as we know, we all have senior and experienced embryologists and clinicians with us today. So, without taking much time, I will like to start this panel discussion. The topic is troubleshooting in IVF lab. So, more of it is related with the technical aspects of the ART procedures in the lab. So, to begin with, so this screen is visible to everyone?
Yes. Yes, Charu, continue.
Okay. Okay. So this is an open for all panelists. This question: what kind of trouble one can expect in IVF lab? Like you are working in an IVF lab as a clinician or as an embryologist. So from both perspective, what kind of trouble we can come across in any ART setup? We can start with Dr. Verma, sir.
Yes. Good evening, Charu, sir.
So what kind of troubles you expect in IVF lab?
So here you pointed out the 4 points: instruments related, lab environment related, manpower related, and record related. And I think that one thing we add power supply related also. So these are covering the whole main troubleshootings inside the lab.
Okay. Any other panelists, their views?
Dr. Saraprit, can you please unmute yourself? You can speak.
Dr. Ved?
Yeah, please tell us what kind of trouble one can expect in IVF lab. Like that, already Dr. Verma told us that all the 4 points, except that he added one more point.
Your voice is not clear, sir. Hello?
Yeah, screen is visible to you or not?
Screen is clear, sir. Your voice is not clear. I'm unable to hear.
So,
Okay, Saraprit, let me explain you. This question is what kind of trouble we can expect in IVF lab. These are some points which I thought and I have written. But as an embryologist, one fine day when you come to the lab, what kind of troubles you can expect that this may be a problem there in the IVF lab?
Instrument, lab environment, manpower, records. I think more or less you have summed up. Gases, you can add gases. There can be a shortfall of gases or any leakage in the gas line.
Okay, let me elaborate this. These are the summary kind of points which I have taken now. Instrument related, if we talk. So can you highlight some problems which you can face along with the instruments in the lab or in sometimes in OT, like suction pump or some kind of trouble? Means
Yes,
actually,
suction
I
pump.
just want to know the actual scenes which you might have come across in your practice of embryology instrument related.
Yeah, instruments. One thing I think we missed on deliveries related also. At times the deliveries also get delayed, and maybe at 11th hour you receive deliveries and time to equilibration may not be optimal. That can also be one of the unexpected problem. In considering the instruments, are you able to hear me clearly?
Yes, please continue.
Yeah. Instruments. See, if you're doing the regular AMCs and PM, everything is in place. Ideally and technically, you should cover yourself up because we usually do split cultures, you split fertilization. We try to split things between 2 incubators. So usually we take care of things, but yes, in optimal circumstances, nothing should malfunction. And ideally, you should be aware of high risk areas in the lab, and you should aim at mitigating the risk. So whatever thing you can think of, you should think and plan well in advance. I always say that you should have 2 aspiration pumps, and 2 injection syringes. These are some things which can trouble you every now and then. So having it may not be required for 2-3 years or maybe 5 years, but at some point of time it will be required, and then it will be a blessing.
Yeah, I have heard somewhere, or I was read somewhere that this manipulator comes with 15 years tear and wear warranty, probably with the RI instrument, what they say. So 10-15 years, this instrument doesn't give trouble if handled properly. Shweta
Even more
madam,
than
I
that,
can,
yeah. Even more than that,
yeah,
the only thing which troubles is, I think, the joystick and the injection syringe. Microscope and all,
yeah.
it stays forever actually.
Shweta
Stereo
madam, would you
microscope
like to?
bulbs, stereo microscope bulbs, they also can, malfunction. Yeah.
Yes. Madam, anything else you want to add? Shweta madam?
Basically, in an IVF setup, most scared thing is like when we are doing egg collection, if the pump goes off. So in my initial days, once it had happened, unfortunately, it was a donor. So we used 50 ml syringe to aspirate, but then I ordered for another pump. So if you're in a small standalone unit, I think so in today's world, it is almost a need to have a backup pump, or if possible even a spare scan machine. But, I mean, I'm telling you from the clinician point of view, because if these two things go away, you are helpless, you can't do anything, and the whole cycle goes waste. So these two things from the clinician point of view, I can think of the instrument related. Other than that, of course, I mean, in the lab, though, everything is so sensitive that we need a dedicated person even for cleaning. We can't send any new person into the lab to even clean. Even the mop they are doing, what percentage of safe and what the ratios they are using to clean. Because if sudden fertilization failure, or I mean, some drop is there, we start suspecting right from who went into the lab to sweep. From there only everything starts.
I will come to fertilization failure, which is most concerned part of day-to-day activity. Manjit madam, good evening.
Yeah, good evening.
You are also working in a lab? Yes, definitely in a
Yes.
genetic lab. But can you throw some light on records related problem one can face?
Yeah, so thank you, sir, for this question. And rightly mentioned, I mean, I am working in a genetic lab, but ultimately a lab is a lab. And it has been, mentioned internationally that man, machine, and method are the three ways, the three areas where things can go wrong. And we need to be really very careful for every aspect of it, every part of it. And as we all know, Murphy's Law, with anything that can go wrong will go wrong. And there are certain days when, there are multiple things that go wrong. So just to ensure that none of that goes wrong, as all the previous panelists have also highlighted some specific issues, for every instrument, the calibration, the preventive maintenance, the AMC, I know it is a lot of expense, but then, when we start maintaining those quality standards, that quality will be an output in our clinical practice. So it is really required for all of that. It is good to have a backup for each and every instrument, and if possible, split the sample amongst two different instruments with different sources of gas, with different power supplies, environment also, the temperature, the humidity, the sterility, all of it has to be maintained in the lab as per the required standards. There are international standards laid out. There are guidelines given by various organizations. And the more we adhere to them, the higher our success rate will be. Manpower, the training, the ongoing training, the hands-on, the efficiency. And, records is something really very important. Mislabeling of samples is something, I mean, Bollywood can just make a movie about it and make a big fuss about it, but it is a fact. It could happen in anybody's lab. So these are the things, I mean, if we walk in the process on the path of quality, there are no compromises in any which way. And it's best to follow international guidelines while setting up a lab and during the running of the lab. That's all.
Okay. Any other panelists want to add anything to it?
Sir, so in
Yeah,
record
I have
related,
one. I have
Yes,
one
yes.
point.
Yes,
So we
madam.
are in Bangalore and we have this huge traffic problem here. And so that is why what we do is we post our egg pickups very early in the morning before the traffic starts. Say 6 a.m. to 7 a.m. we finish everything, because I may reach late later, my anesthetist may reach late, the embryologist may. So timing is very crucial for us. So we avoid the traffic and we reach on time. So reaching on time is very important.
Verma sir.
Sir, so in record related problems, so first main thing is that everyone should have habit to mention the names and proper registration number on each and every dish and disposables. So there are less chances of cross contamination. Because in the centers where too many cycles are going on simultaneously, there are many chances to have the mixing of pipettes or mixing of samples.
Okay. So just to summarize this, what the take-home message we can take this from this thing is that the problem may arise at any point of time in any of the areas, and we have to be prepared for taking up all these kind of problems. Like record related paper documentation, we all know we are in the era of ACT now, and what most important they stress in the ACT is documentation. You should have proper documents in place so that everything is very well known, because many times it has happened that once you do the case, everything is over, and then the technician or the nurse comes and, oh sir, this patient is HbSAg positive. So then this kind of mistake may lead to a big problem for all of us. So Dr. Ved, you would like to take the second question?
Sorry to interrupt, Charu. Can we take expert opinion also in between?
Yes, yes. I'm
And I
coming
think
to Dr.
Timothy has
Jindal, and yes, yes, I'm coming. I'm
Timothy
coming
has
to that.
also joined now. So just
Yeah, yeah.
let's.
So what may be the solutions to all these problems which we face?
Personally think in your previous slide, you came up beautifully with 4 things. Problems with instruments, problem with lab environment, problem manpower related, and record related. Now let's come on to the instrument related. In the instrument related, there are 4 things you need to do. Have a system in which what the embryologist has to do every day, from cleaning to maintenance to everyday checking what he has to do in every equipment. Number 1. Number 2, every equipment needs a backup. Number 3, you need to check all the lines which are coming. Like we check every line every 7th day. It may be the CO2 line, it may be the oxygen line, it may be any line which is coming. So the most important thing is service maintenance, which has to be done in a copy or in a register or in the computer. It cannot be done verbally. Second thing is whatever is to be done in terms of manpower. Just like somebody said, I think Dr. Anuradha said in the morning, you have to reach on time to have the manpower there. Your manpower also has to have a system where on time everything could function. And the third important thing exactly is the record keeping, the labeling, the double witnessing. Even if it is oral, it has to be done. So these are the small things which happen every day. But you know, the real metal of a lab comes out when results don't come. At that time, for you to find why is the result not coming makes you a great embryologist and a great clinician. And that is related most of the times to either the hormones which you are using or the laboratory, which may be anything going on in the laboratory. So that becomes very
I think that's why it is necessary to note down each and everything, whatever you are using in the lab, what are you maintaining, temperature, humidity, whatever, everything you should note down. If anything change in the lab during its last days or month, You just note down each and everything. So it will help to troubleshoot the problem if problem arise.
Okay, so we'll go to now our next thing, which is actual scenes, which I had thought some troubles which may come across very frequently. So why my screen is okay. So now the very first case which we come routinely across, empty follicle. Now, if means this question is to be answered from clinician perspective also and from embryologist perspective also. If an empty follicle are seen and there is no egg coming in the fluid, what will be an embryologist first step? What embryologist will do immediately after seeing this fluid? And as a clinician, what clinician will think of first and try to solve this problem? So we will start with the clinicians first. If the empty follicle is coming, what may be the reason and what is the solution to it? As soon as you come to know that the empty follicles are there and there is no retrieval, no egg is coming, then what you will do as a clinician?
If the HCG injection is not given at proper time, or it is not cold chain maintained, then there may be chances of empty follicle one should face.
Yeah, let's hear from some clinician. Clinician, madam, sir.
Charu sir.
Really.
First, it is a protocol, I think so, in all the labs when the egg collection starts. Embryologists, when they get first egg, I ask them to just inform that egg obtained. Okay, so this is the fixed protocol. And once we finish the first ovary, and when we go to the second ovary, again we tell the anesthetist as well as the embryologist that we are going to second ovary, so that if no egg is obtained, at least they warn us. Okay. So when the embryologists say that no complexes are seen or no eggs are obtained, first thing we'll do is, like in the follicular fluid also, we'll check with the UPT kit whether it's coming positive or not. Okay. And then if there is doubt, we can take the blood of the patient, and then we can again apply for the UPT. I mean, UPT also we do with the serum blood. Okay. And we see whether the HCG was properly administered or not. So these are the things which we do at that time. And we can send the progesterone level and beta HCG levels, but then that report at least take 2 to 4 hours to come. So at that particular time, we can only do the UPT and see why this no egg is there, or COC complexes.
Okay. Can we hear some embryologists? Anyone? Saraprit, are you there?
Dr.
Yes, sir. Yes, sir.
Prakash, you are muted.
Sir, if you come across scene like this, that there is no egg coming, what you will do first?
Sir, it's the same actually what Dr. Shweta has told. We just report it to the clinician, and then they, check the trigger timings and verify with the patient's attendant because patient is sedated. And the UPT thing never worked for us. Actually, we have tried many times, but even in patients who have given eggs and even in patients who have not given eggs, UPT thing never works for us. Actually, I don't know whether we are wrong in doing it.
You get it always positive. That's what you're telling?
No, we never get it positive.
So that means it has not worked, your injection.
No, madam, I was also about to tell this. This probably our expert can tell anything about this, but this I have come across, I have seen myself. You dissolve injection of HCG and you put that drop directly on the kit. Still, it doesn't give you a positive line. Sir, yes, sir.
We've had empty follicles. It's been 20 years. There are a lot of experiences we have, so I'll share my experiences. So when you get an empty follicle, one thing which we normally do is always after picking up the first or the 4-5 follicles, we always ask, follicle pahuncha kya? Ovum aaya kya? Now, if the answer is yes, initially itself, which happens. The most common problem because of which this happens is poor quality of HCG injection. Number one, and most of the times this is the problem. If stimulation has taken place and follicles are present. If they're not present, they're very small, it becomes different. Otherwise, here it will be different. Now, for that, what we have done as a protocol is we only over a period of time, last so many years, only use recombinant HCG. We do not use urinary HCG because of this problem. One, the batch which we use is normally already tested in IUI patients. So IUI patients have already received them. We've seen that there has been a rupture and we know this needs to be used. Supposing there is an empty follicle, you can make out what is the level of the HCG by number one, putting in a paper into the follicular fluid, which we have tried. Not urine, follicular fluid. The second thing which we normally would do is if we realize that there has been a problem with the HCG injection, we normally would not pick up further, give another shot of HCG and take the transfer in the other ovary after 24 or 36 or plan that hours to take it. I've had a patient in which the HCG was not good, gave that patient HCG, we got an empty follicle in one of this thing. After 5, we came to know this was a problem, gave another shot, picked up after that, we got eggs. So it's something which needs to be done. Now, as far as HCG quality is concerned, unfortunately, the quality of HCG in the urinary has become very poor across the spectrum. It's not one company, across the spectrum. In fact, if I can get a vial tested, which I do. Whenever I get a vial tested, because if they can calculate beta HCG in your blood, they can calculate the amount of HCG in the vial which you have, which I get calculated, and I realize that the quantity of HCG today in most of the vials is very poor compared to 5,000. So if you use this, this is what we normally would do. If we get an empty follicle and we're sure there's an HCG problem, we will wait, give another good shot, wait, and then do the pickup after that in the other ovary.
Thank you, Jindal sir, for elaborating it. But from embryologist point of view, what I would like to say here is it's a very basic thing that I would like to focus my microscope, see the settings again give a screening that fluid, and just tell clinician to wait for some time because I am taking some time to find it out. Once I am very sure that yes, there is no oocyte there, then it is declared like there is no follicle, no fluid, no egg is coming in it. So please see, and then we can start troubleshooting. As an embryologist, first thing I will do. Okay, so let's go to the next.
Charu, even sometime what happened that pressure is very high in that the aspiration pump. So sometimes cumulus are very less and only oocytes are coming. So at that time also we should check pressure also that pressure is okay or not. And the second thing we can ask clinician to do the once more flushing kind of thing. So maybe we can get the egg in that. That maybe low pressure or high pressure can affect the follicle that rupture or not may not coming out.
Okay, so now let's come to the next scenario. You see all of a sudden CO2 cylinder pressure is 0. Now, what measures you will take related with regular gas supply, and what if pressure regulator is malfunctioning? Means basically the question is, you see trouble, you have to troubleshoot your gas cylinder. Like you see it is 0, what you will do first? I know the clinician has a very limited role here, only she or he can order or ask for the another cylinder from somewhere. But as a laboratory person, if you see the cylinder pressure is 0, what will be your first thought and where you will see first?
Sir, first thing is don't open any incubators. Don't open them. Let them be in a stable condition, and then start troubleshooting the cylinders.
So where may be the problem?
One should check the
regulator
connection outside the incubator It may be due to the tube leak or tube get out from the inlet. So immediately pressure come to 0.
Yeah.
And if you are having a laparoscopy setup and if there is alternative cylinder is there, then you can replace it with the that cylinder.
हाँ. और सर अभी आपका एक्सपर्ट ओपिनियन के लिए टाइम है अभी हमारे दूसरे पैनलिस्ट को बोलने दीजिए सरप्रीत सर एनीवन एल्स इज देयर मैडम श्वेता मैडम यदि आपको ये पता पड़े कि इंक्यूबेटर का सिलेंडर खत्म हो गया है तो आप क्या करेंगे चिल्लाने के अलावा और गुस्सा करने के अलावा
दूसरा सिलेंडर को अटैच करवाएंगे एंड बेसिकली ये मे बी द प्रेशर वाल्व का फॉल्ट हो तो सिलेंडर बैकअप सिलेंडर तो वैसे भी रहते ही हैं अदर देन द जंबो सिलेंडर
Sir, in all the good labs, there are simultaneously 2 cylinders connected at a time. So whenever such time of problem occur, we just close this first cylinder and open the another cylinder to manage it. And if both the cylinders are empty, then we can replace it with the this CO2 cylinder of laparoscopy setup.
ओके जिंदल सर आप स्टेप इन कर सकते हैं
देखिए मैं ये CO2 का सिलेंडर ऑक्सीजन का सिलेंडर नाइट्रस का सिलेंडर इसका रेगुलेटर सबका अलग होता है CO2 का सिलेंडर का रेगुलेटर is very different from the rest because CO2 basically is in a negative temperature. I mean it's something in which the valve has to be ready to take the negative temperature. So therefore what we do is we have a manifold where we have 4 cylinders, 2 on one side, 2 on the other side. You also get a manifold which is of 2 cylinders, 1 on this side and 1 on that side. If the pipeline is checked, most of the times the problem happens at the regulator area. Now this regulator area has the most problems. So if you have a manifold जिसमें 2 सिलेंडर ऑलरेडी लगे हुए हैं और एक तरफ से आपको नहीं आ रही है तो दूसरे वाले सिलेंडर को खोल के आप देख सकते हैं कि वो चालू है या नहीं है. नंबर 1 सिंपलेस्ट. नंबर 2 जितना CO2 का रेगुलेटर आता है इसमें एक रेगुलेटर आता है डबल रेगुलेटर अगर आप एक सिलेंडर पे लगा रहे हैं. उस डबल रेगुलेटर में पहला वाला मीटर आपको ये बताता है कि सिलेंडर के अंदर प्रेशर के हिसाब से CO2 कितना है और दूसरा आपको ये दिखाता है कि इसमें रिलीज होने के बाद में किस स्पीड पे ये जा रहा है. So if you have this which has this thing, you will be very clear whether the CO2 cylinder is empty or not. And if the CO2 cylinder is empty, then of course it needs change. But if the CO2 cylinder is not empty and the other is not giving you CO2, it means there is some problem in the regulator at the second place. So you may need a spare for that.
I can see Rajul madam is there. She is an embryologist also. Madam is there. Chalo, anyway.
I think she's not joined.
Okay. So in all to conclude down this, what we can say is, as Madam says, backup cylinder should always be there. So I think that is more or less standard practice now that we have 2 CO2 cylinders at least always there. One is filled and one is used in the incubator. And then again, we can have the spare regulators and 2-stage regulator, as Dr. Jindal said, that is the first choice. That should be the first choice. And the another important thing is what I have seen in these regulators are there is various types of these regulators are available. And the most important part of this regulator is the membrane inside that regulator, which depends on the quality of the regulator. So you should always go for a little bit better one, because this is very critical scene for us. We cannot afford in regulator going not working properly and our embryos are there inside. As Dr. Sarapit rightly said, if you come across a situation, then you should not open the incubator, because up to some extent it will maintain the environment inside, and that is good for us. Okay, so move on to our next scene. This is related with the cryo storage facility at the center. and one fine day I need to thaw an embryo and I am not able to locate patient embryo. What may be the problem, why it is not located, and how we can solve this problem so that this should not happen again.
Just check Amok Chimote is there or not.
Dr. Saraprit, I think you take this. I think you do lots of freezing.
सारे ही करते हैं सर.
हाँ, तो इसमें हम क्या करेंगे, यदि पेशेंट का एम्ब्रियो नहीं मिल रहा है तो आप क्या करोगे सबसे पहले?
First of all, I think we should check our records. You should check your soft records and hard copies also, and still try to find it again. कई बार ऐसा होता है कि they're lying in a Vizio-tube or a goblet, but you are unable to find it. Don't rely on the technician. You can try to see it yourself. फिर भी नहीं मिलता है, then you have to उसके आसपास जो और patients freeze किए हैं, check in those vials, check in those containers, and check in those goblets also. And if still you don't get, then probably it has slipped off and fallen off in the liquid nitrogen can. Then it's a very difficult exercise in that case.
Yes, it is very difficult. Take out entire samples outside in the container and then see for the one cryolog lying down there. So, anything else anyone wants to add into it?
Usually, you are doing it through a witness system is also there. Somebody is freezing, somebody is witnessing. Kahan rakha gaya. Usually, since we are discussing troubleshooting, but these are very uncalled for situations, which are avoidable situations. If you work in a more detailed and diligent manner, these situations can be avoided. But once in a while, ho jata hai.
Yes. Yeah, this is what I want to say. This is quite possible, and it can happen at any time. Falling down of the only important thing is that at least we should have that measures or that mechanism in place where if such thing happens, at least we should be able to locate it. And yes, double witnessing is the answer to it, where it has been kept, when it is right, because I have seen personally, I have experienced this when I have frozen embryo and I told that the goblet color is blue, they have written green. And now I don't know, I have said, and then I come across, and then when I see the paper, then I come to know that, okay, whatever's told is not written properly. So always witnessing will definitely help in this. And if the patient embryo is not located, there is no need to panic. मैडम श्वेता मैडम आप सुन रहे हैं, गुस्सा होने की जरूरत नहीं है. You can just find it out, as Dr. Saraprit rightly said. It may happen anytime, and you have to locate. Yes, it's a troublesome exercise, but you have to do it. Dr. Jindal, you have anything expert?
Sir,
Even I
आफत है.
think
अगर हो जाए ना, आफत है, because if you have checked your records, you have not found it. If you see the outer, now the biggest thing to see is the outer leaf and what you hang outside the plastic. Is it available or is it not available? If it is available, it means that it should be there in the cryocap. If you cannot find it, it means it probably will not be there in the cryocap. Therefore, it is very important to find. bahar wali parchi hoti hai na sir. That's very important.
Even I think you should keep all the records. If you are not getting that embryo in that particular area, so you can check your record and check before and after that where you located, where you put all the embryos after and before that particular embryo. So you can locate on basis of that record also.
Okay, so सीमा मैडम हमारे पास टाइम है ना, थोड़ा सा 10 मिनट में फिनिश करूंगा, चलेगा ना?
Yeah.
एकदम चलेगा, दौड़ेगा.
ठीक है. So the next scene is you performed pickup, you did insemination or you did ICSI and all, and next day you see that all oocytes are degenerated. What is the opinion of panel? Why it has happened, and what can be done to see this? वर्मा सर, आप कुछ देंगे इस पे?
Sir, if such type of problem occur, so it may be due to the CO2 supply may be hampered and color of the media may become changed. And if it is dried, CO2, the temperature of the incubator may be rise, and that may create such type of situation as dishes again dried, and lot of debris may be due to the infection if your tip at the time of freezing or at the time of shifting touch any outside surface, so tips become contaminated, and there may be chances of infection in the culture dish.
This may be due to, one, high days, denudation, poor denudation skills, extra, increased concentration of high days, poor ICSI technique. There may be some problem with the injection needle also, which can lead to this. And these are the only reasons, I think. Or inherent poor quality of oocytes, which may be due to not so good stimulation, or elderly patient, or kuch posting kiya hai, post maturity hai, then it can also lead to degeneration. Brown eggs, they usually end up in degeneration. Aged eggs.
At the time of ICSI, sometimes oil goes inside the oocyte, and so on next day when you are going to check the PN, there may be degenerated oocytes in the dish.
That's what I said, poor ICSI skills. PVP andar ja raha to wo vacuole ban jate hain.
It could be also because of, we should check the incubator the previous 24 hours for the temperature changes, the humidity, the CO2, the pH, everything
It
can
will not lead to,
if there is a
it will not lead to,
derangement.
no ma'am, degeneration, it will not lead to degeneration. It will lead to no fertilization. Degeneration is atresia. It is brown colored eggs.
See, we have to see if all have degenerated or a few have degenerated. If a few have degenerated, then it may be that a few eggs have a poor quality. As a poor quality. But if all have degenerated, then it probably would mean there is a variation in the temperature, pH, nutrient concentration, the color of the media which has led to it. It can also be because of the concentration of the gases in the incubator, the way it has happened, which needs to be checked. But in any way, a very cumulative stress which has happened to the embryos at that moment, whether it is genetic, whether it is environmental, has caused this to happen. So I think what is most important at this juncture is to maintain your cool, be calm, find the reason why it has happened, not be angry on anybody, not be even angry on yourself, because there is nothing you could have done, and probably you can.
Yeah, I think
it also depends on whether your dishes are covered with the oil or
no.
not.
Sir, this is a very crucial point which you said. This is what I also feel, that patience must be there, and you have to think of what has gone wrong and where you can correct, because mistakes are bound to happen. You cannot avoid, but at least you can just try to see that next time it should not happen. So anyway, to just summarize this, what I feel, my points are that this may be due to contamination, which is one very common problem. But I feel that nowadays we are so much concerned the semen sample is cultured before taking it for a treatment, and also chances of contamination is very less. But yes, if you see degeneration, very first reason comes in mind is the infection. And this infection, believe me, kind of any infection, you cannot see anything. On next day, you will not see anything in the dish. Next day to it, you will see that there is a debris, or there is a thin layer of some whitish material, filaments are formed, and also that all is the extreme cases of infection which can seen in the culture plate. But what I feel is, like Madam has rightly said, you have to see the culture conditions. Probably even making the dishes for the overnight culture, what you have kept after the ICSI, you have kept the dishes and the oil layer is very thin, or probably it's not covering the complete droplet. That may also lead to the change in osmolarity and ultimately degeneration of that oocyte or blackness of that oocyte. So it's a multifactorial job. But then you very first thing what Dr. Jindal said is that we can see the color change. If the color of the media is changed, then you can just expect there is some problem with the infection. So we'll go to our next. ये फिर अटक गए भाई. Okay. So one sudden day, I went inside the lab and I come across some problem with my manipulator and want to fix it. I know that the spares are there and I can do it, but I'm not able to locate those disposable or spare parts which is kept there in the lab. Or maybe sometime it happens that my junior is at holiday or is not there, and I have to see some record of some patient, and I am not able to find it out. So what can be done in this situation? In this problem, when you don't get the desired material which you require, it is there in the lab, but it's not you are not aware of. Who is able to find and what are the remedies to this?
So, sir, one should always have the habit of before 12 hours, one should visit the lab and check everything proper and at the hand for the working on next day.
There should be a toolbox which everyone knows where it is, and the spares. There should be one dedicated cupboard where it should be, stock books should be maintained and checked thoroughly. And I think it is not a reason that no one knows where it is, only one person. Everyone should know where it is.
Actually, sir, there should be a protocol for keeping everything at the proper place by all the persons, and all the persons must be aware with this protocol. So this type of happening can be avoided.
Yes, so this Dr. Ved, would you like to add something to this? Saraprit sir?
Sir,
हाँ बोलिए सर बोलिए.
I think they've answered it actually. कोई confidential information तो है नहीं कि एक ही आदमी को पता है. Everybody should be aware, and just in case, all this should be the SOPs. It should be the SOPs की कहाँ पे क्या रखा है, कहाँ नहीं रखा. और
exactly मुझे हाँ
जैसे हमारी लैब में हमारा एक प्रोटोकॉल है कि हम all the injection holding whatever is non perishable, I mean expiry date जिसकी long है, उसकी एक रिजर्व क्वांटिटी हम अपने क्लिनिशियन के रूम में रखते हैं. So that if anything falls short, कभी ध्यान नहीं रहता कुछ, so at least you have that reserve quantity. 5 injection, 5 ये बड़े बहुत pipettes, tips, dishes, keep something as a reserve quantity to fall back on in cases of crisis.
Yes, I agree. I do keep holding, injecting pipettes and few dishes. I always keep in my cupboard.
Yeah,
exactly.
So, in the airlines, there is a system that everyone has a training and maintain the protocol. All the persons keep all the things at proper place with the proper method. So such type of happening can be avoided by analyzing the root cause of the problem. And one should always keep the Murphy's law in mind. If anything can go wrong, it will go wrong. So anticipatory measures should be adopted for all the problems.
Even for the vitrification straws, it happens many times.
Yes.
I keep one pack in my room always.
Okay.
But if you are unable,
Madam, you are staying at Bangalore. Maybe traffic.
I take care. I'm extra careful.
I know that you've got a Kashmiri.
We can't take chances. We are in IT city. Will be all over internet if it happens.
नहीं मैडम, but honestly speaking, मैं आज ये बताना चाहता हूँ यहाँ पे कि मैं as an embryologist, yes, I also has few injecting needle, few holding needle, few something related, some deleting pipettes with me, because क्योंकि कभी वहां पहुंचने के बाद मालूम पड़ा कि नहीं है या कम है या कुछ प्रॉब्लम हो गया, तो एटलीस्ट वी शुड बी सेव्ड. एनीवे, सो टू जिंदल.
मेरे घर की हालत.
जिंदल सर, आप कुछ बोलना चाहेंगे इस पे?
सर, एक मिनट सर, just a minute sir. Yeah, so if you could not locate a disposable and spare part and record of a patient, sir, पता है ये क्लिनिशियन ही नहीं, एम्ब्रियोलॉजिस्ट को छोड़ो, क्लिनिशियन गुस्सा होता है इस पे. They become very angry that why can you not tell me the record of this time? But the truth is, when in the lab you have 2 embryologists, 3 embryologists, 4 embryologists,
They
and
can't hear.
and can you hear me now? And everybody feels that probably it would have been kept by the 1, 2, 3. This happens. I'll be very honest with you, sir. Everything has a different register with us. And in every register, everything is entered and signed by, we don't have Dr. Charudat, but our Charudat signs it. The best person who is there, who is responsible, he signs it. And the moment this happens, everything is clear. We normally try to keep a lot of spare, and we always have another almirah in which the stock, the rest of the stock is there. So what happens is that the moment the main stock gets over, there is an almirah which has the spare stock. See, we always have 40, 50 needles or 30 needles over there. We would have our disposables there. Yes, the problem happens in the media, because that you cannot keep in an almirah. That you have to keep which is fresh. So for that, we always get something spare and keep, and everything besides an extra as the oil or as apart from the oil, those which have an extra expiry, like anything which is that normally we would keep a bit extra. In fact, a lot of my friends in my city, if they have this problem, they send somebody to me. And this is a fact I'm telling you, because they know in kya mujhe mil jayega. So God is very kind, but it is a very big problem. It is a very big problem.
Okay, so just to conclude this question, what we can summarize is that, as Dr. Sarabjit rightly said, SOP and its standard procedure should be there. The most important thing which I always like to stress upon, and I tell in the conferences also, and this thing, that the intercommunication, interdepartmental communication, this is lacking. Means I remember that when I visited Belgium, they used to have a departmental meeting every Saturday, just sitting, gossiping, talking about the patients, talking about what we have done last week, what we are going to do next week, how many cases are expected, what is the right now stock, what is if there any particular case. So these all things are discussed amongst themselves, so everyone is aware. And similarly, if the standard operating procedure in place, then no matter whosoever is working in the lab, I think this problem will not happen, because everyone is following those protocols. Okay, so we'll go to now this is very important from clinician point of view also. So sudden drop in pregnancy rates, when you see that in a routine lab you are working and all of a sudden you find that in last month the pregnancies are very less. It's not up to the mark, what the benchmark you set. So what may be the causes, where to look for, and how we can improve? Sarabjit sir,
first thing is you have to see whether you've made any changes. I mean, it may be as small as changing a plastic dish or a pipette, or
media.
Going up to media. Media is something major, but even anything which is coming in contact with the gametes, any injectable also, for that matter. I mean, you have to see if you have made any change, and so the effect is apparent in the results. So you have to reverse that change. You have to go back to where you were. And there are multiple causes actually, there is no end to the list of causes, but this is the most common thing which we have to observe.
I would say that
if the embryos are good quality and you have a pregnancy rate drop, yes, we have to check in the end when they loaded the embryos, was there any problem at that time? Or in, of course, the doctor would have been doing a lot of embryo transfers. Did any junior do the embryo transfer? Who did the embryo transfer? That's also very important. Was the embryo transfer difficult from clinician point of view? So these technique of transfer, the lab, if your embryos are good, when you load just right from loading to transferring, there will be problem. Was there more time taken to transfer the embryos? Again, the pregnancy rates can drop. But if your embryo quality is not coming good, that obviously will lead to pregnancy drop. Then it is at the clinical level. Have you changed the protocol, the drugs? You have to check the batches, the triggers, everything has to be checked. And who did the scans? Was the trigger given prematurely, that you got less eggs or whatever? So clinical level and lab level, and from the lab to the transfer level, all the things will depend on what you get as embryos. Thank you so much.
श्वेता मैडम, आपका नंबर है.
I'm so sorry if some messages are coming randomly to vote and help them. So I think so. Sarabpreet sir has already told very nicely. Whenever this happens, we always evaluate what was the change that happened, isn't it? And right from injection, cold storage, refrigerator, and to media changes and everything. And I have worked at the best of the labs. I have worked at ANOVA, and now I have my own center. And like we have like modular OT and AHU and backup, inverter, transformer, everything now. And previously also at NOVA, we had all this. But there also I have seen the failure of the whole system. And overnight, the embryos were in that incubator. And they have also given us pregnancy. So above all, Almighty is there to help most of us. And we put best of the technology and still it fails. So maybe Jindal sir can put it very nicely what I want to convey.
So, sir, what I feel is there are two aspects of it, the clinician's aspect and the embryologist aspect. So from the clinician aspect, you have to see what is the quality of the patients which you are doing lately. Are they failure patients or they are first timers? Are they difficult patients? What have been their diseases? So that is going to give us a very fair idea that if the patients which you have done lately at this particular time when you feel it's a drop, are they difficult patients? Are they different patients? Are they patients which are failure, their age is more? One. Number two, as a clinician, you have to scan your ultrasound reports. You have to scan the doses which you have given. You have to see the hormone which you have given. You have to see the trigger which you have given and the timing. This is something which you need to calculate on paper. And since everything is there on paper for every patient, you can find it. First thing. Second is, then you see the lab reports. In the lab reports, you have to assess the quality of the oocyte without denudation, the quality of the oocyte after denudation, what has been the fertilization assessment of there, and what are the kind of embryos which you have finally got. And has the transfer been done? At what level? How the catheter has been? Or is there somebody else who's doing a transfer for that? Which will give you a very, very fair idea if something has gone wrong, where. So it becomes very important for anybody to find if there is a sudden drop in pregnancy rate or what is the reason, because that needs to be corrected. And it can be something very small which has happened. But then you have to judge what is the level at which the problem has happened. So this becomes important.
Very nicely said, sir. Now we come to Dr. Mehta's question. I think this is very relevant in today's scene, that we come across this recurrent implantation failure or failure cases. We have tried 3-4 cycles and still the pregnancy is not achieved. And in spite of good embryos are formed and everything was up to the mark, and all, still the pregnancies are not coming for that particular patient. So what next we can give option to that patient and what should we screen for. So we have Dr. Mehta with us. Probably she is the right person to tell us about this genetics in implantation. What and where we can suggest the test to the patient. Dr. Mehta, are you there?
Yes, sir.
Yeah,
And
yeah.
thank you for this question. And yeah, I'm going to restrict to the genetics part. And see, today in this so-called post-genomic era, you know, the whole human genome has been cracked. We know exactly what gene causes what function, what gene plays what role in that, what are the variations in each gene. All this information is now available and also clinically translatable. So the entire process, right from the invasion, angiogenesis, and all the processes in the embryo implantation, we know all the genes those that control those processes. The polymorphisms or mutations or changes in these genes that are involved in these processes could lead to implantation failure. Abnormal karyotype, like going back to basics and chromosome testing and all that, we have parents who could be carriers of a translocation, balanced translocation. Sometimes there could be an abnormal karyotype in the embryo, which could be cause of implantation failure. Broadly, if you see the 2/3 of implantation failures, they say are due to inadequate uterine receptivity, and around 1/3 of these is due to the embryo itself. Coming to the tests that you have mentioned for males, of course, the general tests are definitely done beforehand, like a low sperm count, motility, abnormal morphology. All this can affect fertilization and the embryos. As far as genetics is concerned, we have the sperm DNA fragmentation, and that is also associated with failure. Y chromosome microdeletion is another test which is generally done on the male partner. And you'll be surprised to hear that we see a lot of carriers of the mutation in the CFTR, the cystic fibrosis gene. Now, you know, males having this gene mutation, they have congenital bilateral absence of vas deferens, and that is causing infertility in men. If you go to the female factor, the maternal factors, you rule out the thrombophilia, the immunological, metabolic infections, and those. And coming to the genetic test, as you have rightly mentioned, is Fragile X. So Fragile X in males, while it causes mental retardation, in females it leads to, it's called FXPOI, Fragile X primary ovarian insufficiency, or premature ovarian failure, POF. Besides that, as I said, you know, we are aware of several genes, and certain labs have designed a male infertility panel, a female infertility panel, which covers genes like, you know, P53, VEGF, COX2, LIF, and those are the kind of genes. All of them play a role in the entire process. It is good to rule out any kind of a balanced translocation in the parents. And other, you know, we have killer cells, we have these HLA mismatch and immunotherapy, which we do. Also, now since we are talking genetics, I'd like to mention PGT. We do PGT of the embryos and the blastomere of 5 stage. And PGT-A, as you all know, is to rule out aneuploidy in the embryo. PGT-SR is for structural rearrangements, and that is done when one of the parents is a known carrier of a balanced translocation. And then we have PGT-M, which is for the monogenic disorders. If one of the parents is there's a known mutation in the family. Lastly, a word about genetic counseling. It's really very important for the entire process to be explained, and what are the tests, what are the limitations, what it can give information, what it cannot give. All this is covered in the genetic counseling. And today there are so many tests. So which is the right test that is available? A geneticist will be able to tell you. Thank you.
So basically the question, what I, as a general person, I would like to see that if the pregnancy is not happening, I have done 2 cycles, what should as from genetic point of view, what test should be done for that particular patient? What should be advised to that patient? Or you say that there is some basic genetic test which can be performed prior to start treatment and then proceed with the procedure.
Yeah, you could do it before or you could do it after a couple of failures. Like when you have reached the stage where there have been a couple of failures, then you need to go back, step back, and then look at all these possible causes of it.
Is there any particular indication for Y chromosome microdeletion test?
No, there is no. I mean, they say
in every patient we can go for that microdeletion.
Yeah. I mean, again, you need to wait, and then it's not required for everybody. Whenever there is a male factor infertility, how do you know it is due to a male factor? So when the couple presents as an infertility, it is part of the male workup that we do.
So this situation we come across many times, madam, that patient asks, आपने कहा sperm है, आपने कहा अंडे अच्छे हैं, embryo अच्छे बने हैं, और still the pregnancy is not achieved, then we have to give them some logical answer to it, and then probably genetics might be of help in explaining them that why this has happened. Jindal sir, आपका last comment इसके ऊपर expert comment.
सर देखिए सबसे इम्पोर्टेंट चीज जेनेटिक्स तो है ही, बिकॉज व्हेन यू गेट इट डन you are really able to explain to the patient the thing which is going on. There is no doubt about it. And the most important thing in any line in which there is 60% failure and people have paid, the question they are always going to ask you is, why has this happened? Now for them, the fact remains that if you have genetically tested them earlier and done all the relevant investigations for them earlier, you will not get them done in the second go when they will ask you, "Aapne pehli baar kyun nahi karaya?" So that becomes very important. It's a very, very practical thing which I have seen. And as it is, since I deal a lot with male fertility, getting for any patient a karyotyping Y chromosome, and of course, cystic fibrosis kami karana padta hai because VAS is mostly there. But getting these tests done become very important for the prime reason in all the micro TCAs. Let me be honest with you. Say about 2 out of 10 have a Y chromosome. And it is in the region that I will get no sperm. So why subject them to this process? So it becomes very pertinent. But yes, explaining this, any line in which there is 70% to 60% failure, to still have a patient who comes back to you again and who believes in you is important.
Okay, so the time is we have time constraint. I'm constantly receiving message from the organizers that time is over. So let me thank all of you. It's a wonderful thing to interact with all of you, and yeah, so I would like to thank all of you, and I will hand it over back to the Seema madam. Please go ahead.
Thank you, Charu. And I'm extremely sorry just because this platform like timing is going to end. So we'll not be able to wind it up. That's why I was hurrying. It was a wonderful discussion. Thank you, our moderators.
Dr. Tarini has come.
Yes, I'm coming to that. Thank you, moderators, Dr. Charu Dutt, Dr. Ved Prakash, our expert, my favorite, Dr. Sunil Jindal Boss, and wonderful panelists. It was a wonderful session, very, very practical, and yet we have to learn all these things. Now, one of the guests of honor who has been waiting patiently for us to welcome her. She was not speaking anything. I would like to welcome our guest of honor, Dr. Tarini Taneja, Chairperson, Delhi Chapter of ISAR. Welcome, ma'am. And please say a few words before we just get lost on this platform. Ma'am का CV लगाओ. Dr. Tarini Taneja, ma'am, is Chairperson, Delhi State ISAR, Chairperson elect SPAT, Delhi State, Congratulations, Madam. Executive Member, South Delhi IMA. She has held so many positions in FOXY as Chairperson, Breast Committee, Board Member, Breast Care Group, Board Member, Journal Ops Gynae Research and Practice, Vice President, Women Wing of DMA, Executive Committee Member, South Delhi IMA. And she has written multiple articles and she's got multiple accolades and awards like Bharat Gaurav Samman Award, FOXY late Dr. Kutti Lifetime Achieve Award. I welcome you, ma'am, and we would like to hear a few words from you.
Seema, hi. Thank you so much, Seema. Hello.
Hi,
Hello,
ma'am.
Seema.
Hi,
Yeah.
Dr. Tarini. Hi, Tarini.
Seema, I'm really not guest of
Good evening,
honor for you. I'm your friend, rather to say. So first of all, I think everything has been wind up. The last one. So first of all, greetings from Delhi, sir. All the best for all of you. You're a good team. So I'm really pleased to see the Star Studied webinar and so much interesting panel I was holding in this embryology lab. And I know both of you, rather team, you, Aradhana and Dr. Anuradha Kaur. You are so, united. It's a good team. I think whenever you go, you will be the cause for the success and the progress of the TV and the organization. So I wish all the best. Oh my God. Dusri Mahadana. Just a
Thank you,
minute.
Dr. Tarini.
So I wish
And
all of the best. I think all public are request to vote. And voting has been started. So you are passionate for the PCO, I think for awareness. I know very well that's the thief of the womenhood. I will not take much time. And Aradhana is so much, dedicated fertility, especially she's the winner of the National SR Quiz Clinical and so much places she is visiting. And what to say, I want to appeal to vote everyone to take their right not to wish and elect the important person. So thank you so much, Dr. Seema and Dr.
Thank you
Aradhana.
so much. Thank you, Dr. Tarini.
Words mean
Thank
so
you.
much. A
Thank
lot.
you.
Raki, thank you very much for
Shweta,
attending till the
and
last.
Tarini, please wish Shweta and Manjeet best of luck too. They are
Okay.
also contesting.
Shweta,
And this
best of
embryology.
luck.
Thank
I
you, ma'am.
want all of you to see as a team and Dr. Manjeet. Actually, I wish.
Madam Manjeet. Yeah.
Oh, Dr. Manjeet, you were there. My God.
Yeah, it's so good to
I
see
didn't
you.
see actually complete. I was so busy. One IVF conceived patient, one laparoscopic treated. So I was busy. I had to leave to Delhi. Tomorrow's my program of Delhi. Sir, if you are there, please join me. Sir, New Year celebration and one panel on ovulation induction. So please
Thank you
join
so
me.
much.
And one meeting is like Vidhan Sabha tomorrow in the morning. So I don't know how will I manage. So I'm stuck here. Anuradha, hi, hello. All the best for you.
Thank you,
Everyone.
ma'am. Thank you.
Thank you, ma'am.
Thank you, ma'am. Thank you.
Thanks for your blessing, ma'am.
Did I end it before it goes off the air?
Ma'am, can I comment? Can I
Yeah,
comment?
Dr. Raki, please.
I want to thank.
We want to listen.
Officially, I want to thank our partners, Delhi ISAR, Haryana ISAR, for giving their free hand and their welcome and wishes to us, and our academic partner, Corona Connect. And I again thank my chief guest of honor, our moderators, master of ceremony, and all the esteemed faculty for joining this webinar, and our wonderful audience who had been staying with us for last 3 hours, more than 3 hours. It is going to be 3 hours. Thank you so much. And this
Thank you.
embryology panel with these 2 moderators and this
Fantastic.
expert we are
Good.
going to experience
Super.
very soon.
Yeah,
It was really,
super.
it is need of the day, and we have to do it more frequently. Dr. Ved Prakash, Dr. Charu, and Sunil Boss, आपको ये
Ma'am, you're
panel
doing
फिर
the
से
work
करना
of
पड़ेगा.
chairperson.
And best wishes.
Doctor, and
all the
you,
best.
now,
All the best for the
Raki,
university.
please, I'm going to you, please, Rakhi. I'm sorry because मुझे डर लग रहा था वो तो गड़बड़ ना हो जाए, Rakhi. And my chairperson.
Actually, my name is started from the Y, so always my name come in the end and last candidates.
Dr. Rakhi, Dr. Professor Anuradha.
You were from the beginning. You were added from the beginning.
Yes,
Rakhi
I was
Rakhi
thinking
Hello,
Dr.
Rakhi.
See,
Dr.
I want
Madam.
to compliment this organizer of this webinar. It's wonderful, and we need to look out for more. And hats off to the vision of Dr. Anuradha and its co-organizers. And full support of Haryana chapter of ISAR. I want to say to the candidates and best wishes. And the moderators of this last panel were very awesome. The choice of questions were great. And I just want to compliment them. They had really done a great hard work and picking all these scenarios in troubleshooting in IVF. And I want to add here one thing. Always, whether we are doing IVF or whether we are doing any other procedure, one day before we have a checklist and we have dedicated person in there who only does this thing to check the whole from A to Z. So we have maintained a register A, B, C, D, E, F, G, H, and there's one dedicated person in the hospital who checks all everything is in the order. So that's what I want to add in this whole matter. And congratulations to the moderators. Very nice. And all the panelists, they were really awesome. God,
All the best for the
Thank you.
elections.
Thank
And
you.
all the best for the elections. May you all win. That's the way it's got to be.
Seema madam, I just like to highlight one important thing in today's webinar. Very first time we have seen a senior genetist also joining in this webinar, and I think this is a very good initiative because genetics is an important and integral part now
very
of
important
our IVF. And I know Dr. Mehta, ISPAT Society. So more and more ISPAT, ISAR type of meetings we can plan in future, and we can have advantage of having such wonderful genetics with us. So this is a really very good initiative. Thank you for
Dr.
this.
Charu,
Thank you,
congratulations.
sir, for
It was wonderful panel.
Thank you,
Everyone
thank you,
was
madam.
very good.
It's my
very
honor
good.
to be part of
Fantastic.
Everyone
was
should
amazing.
vote, ma'am.
Yeah.
If you
And
want
one
geneticists
thing,
in the SAR.
Dr. Aradhana, you're such a good team. And good team is really cause for the progress and success. So I think it's good to come, all of you.
See
I
you.
would request
See
I
you
would
all very
request
soon
all
in
the
next
Isarians
ISAR,
to
Bhubaneswar.
vote for Dr. Aradhana, myself, Dr. Shweta Jha, Dr. Manjeet for member managing committee, and Dr. Seema Pandey for as librarian. So I request all of you to vote for all of us. We are academically very, very oriented, and I think we will be a good team if we come into ISAR committee.
I
Thank
want
you
to
so
say
much.
few words.
All the good wishes,
I'm
Dr.
really very
Khan.
thankful to all of you who have taken some time from your busy schedule, because I called whosoever I called, they just said yes. Aradhana, तुम जहाँ बोलोगे हम आ जाएंगे. Madam Tarini, she's so senior. I mean, she's so busy. She said, Aradhana, okay, I'll be there. And Madam Manjeet and Dr. Y.S. Verma, Anju, and everyone, none of them they say ki we can't come. Whosoever I call, everybody. I mean, I'm really very thankful for such a big support, and really, I mean, this is really awesome that we are working as a team, and none of us is like competing with anyone. And I really pray that everybody present here should win.
It's been an amazing webinar. Thank you, Dr. Aradhana, for getting us all together.
Ma'am,
And
Anuradha,
last
can
few
I
word for Dr. Seema. She is working so hard. I mean, 24/7. She is, I mean, working and working professionally, academically, and making as a team, and with coordinating with so many people. Seriously, and still looking so fresh and pretty.
Absolutely. That's the best part about her.
Seema,
She's
Seema,
an
which book
amazing
is
person.
releasing? Seema, which new book you are releasing now?
So there are two pending. लेट्स
Yeah.
होप AICR तक आ जाए. ART आ गई है, बहुत अच्छी बुक है, प्लीज पढ़िएगा. लेकिन अब मेरे को कोरोना वाले पीटेंगे, इसको बंद करते हैं. मेहुल,
Okay.
Bye bye,
sorry, I
everyone.
Thank you, everybody.
Okay, bye
Yeah.
everyone.
Good night.
It's been a
for
wonderful
Thank you.
notice.
Thanks
Thank you.
Very nice.
everyone.
Thank you so much. Thank you.
Thank
Thank
you.
you. Thank
Ved
you.
Prakash and
Thank you,
Charu,
ma'am. Thank you
thank
so
you
much.
so
Thank you.
much, and all
Vote,
our
vote,
panelists.
vote.
Let's meet in Bhubaneswar, as Dr. Yatin said. Dr. Yatin, thank you
Yeah.
so much. Let's
You are
meet in
always welcome.
Bhubaneswar. And best of luck to all of us. Bye-bye. Take care. Good night.
Wish you all the
Bye.
best.
Thanks
Good night.
everyone. Thanks sir. Thanks Anju. Thanks Shweta.
Thank you,
Thanks Charu.
thank you, ma'am. Thank you.